Thank you. Good morning. Happy Monday. It's rainy, the weather is awful, but happy Monday. All right, so over the weekend you had two chapters, chapters 2 and 3. I know they were long. That's the worst homework that you're going to have over the course of the class. Each weekend you'll have two chapters, but the first weekend is by far the longest and the most dense material, okay?
The definitions that it gives us throughout the things, should we be making, like, copying, writing them down? Are those on the test?
So on the bottom of your page 181 and 182,
Right.
183, so you have definitions there that are matching. Those are the ones you need to know.
Okay.
If you know those, you're fine. So let me explain to you, since you brought it up, let me explain to you a little bit about the written test. The written test is not what you expect it to be. And this is a huge kind of misnomer about the test. We are used to taking tests that have us regurgitate information. So definitions, body systems, these are the types of tests that we take in school, right? You learn something and then you prove that you learned it. That is not what the written test questions on the state exam are. The written test questions are application questions. They're not asking you, do you know what abuse is? They're asking you, if you see this in your patients, what are you going to do about it? So you have to be able to recognize abuse. But the next step is, what do you do with that information? So they're application type questions. So to go back to what you were asking is, are these bolded words that you're reading, the definitions, are these going to be on the state exam? And the answer is no. Nobody's going to ask you, what is another name for decubitus ulcer? Or what does OBRA stand for? Those aren't questions you would get on the state exam. You would get a question, for instance, you're working in a residential long-term care facility and the patient is complaining about other staff members and wants to talk to somebody. Who is the somebody that they would talk to? Okay, and the answer there is the ombudsman, the unrelated third party that is there to mediate between residential patients and the facility staff. Now, why do we need that? Let's think about that for a second. Why do we even need an ombudsman there? Why couldn't that patient go directly to the director of nurses and say, hey, I got a problem with this CNA? Why do you think that would be a problem? Anybody know?
Like, they're more like a mediator, because they're not involved with the nursing staff.
Right. So that's the problem. If I'm the director of nurses and all of you guys work under me, right? And a patient comes to me, this patient here, and says, hey, I don't like this CNA. She's really rough with me. She doesn't listen. Whatever the case may be, right? I could listen to that person and I could make changes, certainly. But do you think that all administration is going to do that? What if you were my best friend?
So it's going to be somebody that's outside of the nursing.
Right. Now, this is where the patient lives. It's not like a hotel. You go into a hotel, if you don't like it, you can check out and go somewhere else. You've got freedom. This is where they live. They don't get to hire you. Think about that for a second. These patients do not get to pick their caregivers. The people that will see all of them, the good, the bad, and the ugly, they don't get to pick you. They don't have any say in who's hiring or, who's hired or who's going to be assigned to them. They're stuck with whatever they're given. Now, on top of that, you have to understand that there can be some power plays here. Okay. And then you've got staff loyalty. And a lot of places, it's an us versus them mentality. So if a patient is stuck in one of these situations and they complain, retaliation is possible. And that's why we need that third party, not so much to be a mediator, but to prevent retaliation from occurring. Does that make sense? So we would need to know what an ombudsman is. They're not going to ask you what is an ombudsman. We need to know that if a patient is complaining, that's who they need to be directed to. Good? Make sense? So these questions that you're going to get on the written test are application questions. They're going to ask you, what are you going to do when you see this, hear this, when this situation happens, when the patient says this? They're very, very few what we call didactic questions or concrete questions that just ask you to regurgitate information. They're not going to ask you which of the following organs is in the digestive system. That's not really relevant to who you are and what you do. Understanding how to respond to a patient when they say, I don't know why I'm still here, that's very relevant to your role. And remember, we read the room, right? We respect, we employ empathy, we acknowledge. So if somebody says, I don't really know why I'm still here, we can acknowledge that must be very frustrating for you. Would you like to talk about it? We encourage. Make sense? Okay. Does that help with your question? Definitely. Okay. But the I pulled out, because I made these tests. At the bottom there, all of those definitions, those are terms that you probably should be somewhat familiar with. Maybe not necessarily for the test, but certainly when you're working, these are things that you need to have some familiarity with. Okay. So if you're going to make flashcards, those are the ones I would stick with. Okay. Hey, Jake, that Julie's TV over there is stuck. Mine's okay.
We're getting all sorts of connection issues right now.
Okay.
Both of the monitoring PCs are struggling, but the actual YouTube feed is staying relatively consistent.
Okay, good, good. All right. So let me go ahead and get your scores for chapters 2 and 3. So you should have taken read chapters 2 and 3 in your yellow book, taken the tests on page 182 and 183 in your white book, your spiral book, and then graded them. So when I call your name, tell me either how many you missed or tell me your score if you did the conversion. Delilah? Thank you. Jenny? Okay. Isaac? Thank you. Fermana? For both? And do you have chapter 1 for me? Page 181. If not, that's okay. No, next time. Okay. Victoria? Kaylee? Thank you. Diana? Naomi? Andrea?
90 and 85.
Thank you. Sarah? Thank you. Daisy?
90 and chapter 3.
I'm sorry.
90, and then I'll do the chapter 3.
Okay. Teresa?
I went on chapter 2 and I didn't do chapter 3.
That's fine. Christian? Faith? Okay. So those of you who missed any of the questions, is there anything there you want me to go over with you? Any of the questions that, if you don't know why the right answer is the right answer, now's the time to ask, because I'll explain it in a little bit different way than the book does. So does anybody have any questions you want me to go over? No? Everybody good? All right, then. How do we know what to do with each patient? We follow the care plan. We follow the care plan, the whole care plan, and nothing but the care plan. While we're doing that, we should be making observations. That's right. And what do we do with those observations? Report it to the nurse. Even if we think that it's really not relevant, should we report it? And the problem there is that you don't always know what's relevant and what's not. Even very, very small details that you might think are, no big deal, could indicate a change in the patient. Here's one that gets missed every so often with CNAs. Your patient, when they're in bed, complains of itching. When you get them out of bed, they're fine. Next night, you put them in bed and they complain of itching. That's a very minor observation, right? But it can actually indicate several things. It could indicate a bug problem, physical maintenance. It could indicate an allergy to the detergent that the sheets were washed in. But it could also indicate a liver problem. So something that minor, we still have to report. Okay, make sense? Good. All right. Every skill starts with an opening. Every opening starts with a knock. Yeah, so we're going to knock first, and then we're going to enter. When we enter, we greet the resident. We address them by name. Hi, Mrs. Jones, or you can ask their name. Could you please state your name? Either way is fine. And then we're going to introduce ourselves by name and title. And this is important. They need to know who we are and what our role is, that, how we're going to relate to the patient. Because every type of caregiver is going to relate to the patient a little bit differently. Good. Once we've got all the introductions out of the way, we're there to tell them what we're about to do. So insert name of skill here. And then we're going to get what? Consent, permission, the okay. Do we touch somebody without their permission? No, that's actually can be considered battery. So in extreme cases, so make sure you're getting consent. But the other issue here is it's more than just legal, okay? If I regularly trample on your rights, so let's say in this classroom, right? Let's just pick on you guys. If I make you stand, if I just pick one of you, okay, you're standing today. Next class, you're standing. The next class, you're standing. I don't let you sit. If I don't give you access to the bathroom, I hand you an adult brief and say, just go in here. We'll clean you up later, right? If I regularly trample on your rights, do you think that you're going to trust me? How many of you would quit coming to class because I made it uncomfortable? Because even if I didn't pick on you, how do you know I'm not going to pick on you next class, right? I've kind of shown my my personality, the way that I relate to people. Does that make sense? Right? I've demonstrated to you who I really am. When people show you who they are, you believe them, right? So when we're working with patients, if we aren't protecting their rights, if we aren't treating them with empathy and respect, they are not going to trust us. And they may, in fact, start becoming very resistant to care. These are the people that say no to everything. People that say no to everything generally say no because it's the only way that they can pull back control. That tells me a lot about the care that they may have been receiving. Does that make sense? So this isn't just a nice thing to do. This isn't just something we have to do for legal reasons. This is how you get your patients on board with what you're trying to do with them, so you're not fighting them.
What happens in a situation if we do have a patient that says no?
Great question. So remember on class 1, I said that CNAs only have 2 doors we can walk through. We either follow the care plan or what's our other door? Tell the nurse. So if we go in, we introduce ourselves, we tell them what we're there to do, and they say no, well, then we can't follow the care plan. So what's our only other option? Go tell the nurse. Now, when you come to me and say, hey, Mrs. McGillicuddy won't let me do foot care on her, I'm going to ask you why. Now, if you've got that information, that puts both of us ahead of the game. So when you tell Mrs. McGillicuddy, I'm here to do foot care, and she says no, you probably should ask nicely, can I ask why? Is this a bad time? Are you in pain? Are you expecting company? You know, what's going on here? So I can let the nurse know. So we're going to try to find out why. We're going to gather more information. And then when we go let the nurse know, hey, she wouldn't let me do foot care because she says her back hurts and she wants to go back to bed. Well, that's an observation. That's something the nurse needs to examine. So we've kind of killed 2 birds with 1 stone, because otherwise we may not have even known about the back pain. Good? Make sense? So those types of questions will be on the state exam. What are you going to do when a patient refuses care? Because that's an application question. It's very relevant to what we do. What are you going to do? Well, the first thing we always do is encourage, right? We encourage them to do whatever is on the care plan. But if they continue to refuse, that's okay. We're going to find out why, and we're going to report that to the nurse. That's it. We don't, we encourage, but we don't force, we don't manipulate, and we certainly don't ever threaten. And a lot of CNAs make that mistake. Well, you won't get lunch today if you don't let me do this. Or without a bath, you're not going to the activity center. That's not our role. And again, what we're doing is setting up, this is where the patient lives. We're setting up a hostile living situation for this patient. How would you react if you were threatened in your own home by somebody else there? Me, I'm slamming stuff. Don't you dare threaten me. That is absolutely out of consideration. Not going to happen. Well, our patients really don't have that ability to act out. That means they have to internalize it, which means they're probably going to be harder to work with. Does that make sense? So this isn't just a nice thing to do. It's not just a legal thing to do. This is how we're going to set up all of our patient encounters from here on out. Because if they don't trust you, they'll never trust you. You're not going to win that back. Good? Make sense? All right, so once we get permission, then we can close the curtain. Is that curtain clean? So what do you want to do after you close the curtain? Go wash your hands. Yep. And then after you wash your hands, you can get your supplies. Remember, clean hands are needed to get clean supplies. Good? Good. Okay, our cardinal rule here is do not touch your patient until your hands are clean, ever, for any reason. We also learned glove rules, and we spent a lot of our time on Wednesday on infection control and glove rules. So when do we wear gloves? There's 3 reasons we might need gloves. So if we're going to touch body fluids, if we're going to touch personal skin, or if we're going to touch non-intact skin, wounds, rashes, sores, or incisions. Good? Good. If we go through our checklist, and let's say I'm going to do range of motion on this patient, there's no body fluids, I'm not touching personal skin, there's no non-intact skin, I don't need gloves. I'm going to wash my hands before I touch the patient for them. I'm going to wash my hands after I touch the patient for me. But if I'm going through my checklist and I realize that this patient has a rash on the arm that I'm about to do range of motion on, now I need gloves. So if I decide that I need to wear gloves, when should I put them on? Before I do my opening? Okay. Should I put them on before I get my supplies? Should I put them on right before I touch the patient? Okay, so if we're going to wear gloves, we've got to be careful and put them on at the right time so we're not touching a lot of things in the environment, contaminating those gloves for the patient. It's like our sandwich. Those gloves touching everything and then touching our sandwich didn't really do what we thought it was going to do. Good? Questions? Okay, when we decide to wear gloves and we put them on and we work with our patient and we get body fluids or personal skin or non-intact skin stuff on our gloves, we want to really pay attention to what we're touching in the environment. We don't want to cross-contaminate. And then we have to remove our gloves properly. Oops, I'm going to slide behind. Want to remove our gloves properly. We pinch up at the cuff, glove can touch glove, and then we go underneath for the second glove. So glove can touch glove, skin can touch skin, they can't cross. Good? All right, we learned barrier. Anytime we use supplies, we use a barrier because it gives us a clean place to put our clean supplies. We only touch supplies with clean hands. We've learned that. Remember, all of your supplies are clean, and you don't let those supplies touch your uniform because your uniform is not clean. And the best way to do this is to go get your barrier before you get your supplies. Go get the barrier first, put it on the table, go get your supplies, put those on the barrier. That way you don't accidentally hold things up against your uniform. Good? Okay. We learned privacy blanket. This is not just for privacy. We have a curtain for that, but the privacy blanket is going to provide an additional layer of privacy between the patient and us, but it also provides for warmth. Remember that your perception of temperature in a facility is different from your patient's. We're going to use a privacy blanket anytime the patient is uncovered or undressed. It will not tell us in the care plan to use a privacy blanket. It will not tell us in the care plan whether to use gloves. It will not tell us in the care plan whether to use a barrier. These are things we have to know in order to apply. Good? Makes sense? Do you guys understand the difference between the care plan and the principles? Okay. Principles are things we know in order to do what's on the care plan. Questions so far? Okay. If we're going to put the blanket on, we put it on over the sheet, pull the sheet down underneath so the patient's never completely exposed. We don't snap or shake that blanket while we're putting it on. And then at the end, if we wore gloves, you may or you may not, depending on the patient. If we wore gloves, we take those gloves off first before we take the blanket away, because you don't want to touch that sheet that's going to go right up next to their face with soiled gloves. Questions?
I have a question on gloves. I wear gloves a lot, and when my hands get wet, it's very hard to put the gloves back on. So as many times as you got to wash your hand, put the gloves on, wash your hand, put the gloves on, how do you fix that? Because it's very hard to get the glove on when your hands are wet.
You want to make sure you're drying thoroughly. Yeah. That's really the only, the only way to combat that. You can, air dry, wash your hands, dry them, and then wait a few seconds to put your gloves on. Remember, you still have to get your supplies. You've got to put a privacy blanket on. You've got to prep the skill. So by the time you get to the gloves, your hands should be dry.
So you got to kind of calculate everything before you put the gloves on. So you're going to wash your hands.
Well, remember that everything you touch with those gloves in the patient environment is going to contaminate those gloves, right? So if we wash our hands and put our gloves right on right away, and then get our barrier and put it on the table, then get our supplies and put those on the table, then put the head of the bed up, then put the towel on the patient's chest, then put the toothpaste on the toothbrush. By the time you start brushing that patient's teeth, look at all those things those gloves have touched. Are those gloves clean for the patient? No. So the error here was putting our gloves on too early. Does that make sense? And when you wash your hands, dry them, and then put your gloves right on, you're putting your gloves on too early, but it makes it hard to put them on because your hands are still wet from washing. Okay. If you do it the way that I'm explaining to you, if you wash your hands, dry them, and then get set up for the skill, putting your gloves on right before you touch the patient, there is a period of time there that allows your hands to dry a little bit more before you're putting your gloves on, which makes them easier to put on. Does that make sense? One of the biggest errors in healthcare is wearing gloves when we don't need them, putting them on too early, and taking the steps that we think we need to protect ourselves rather than thinking about those gloves as being protective for the patient. Does that make sense? So let's go back to Wednesday real quick. Let's talk about the sandwich, okay, when it comes to gloves. We decided at the very beginning that we wanted the sandwich worker to wear gloves because we didn't want the worker to touch our sandwich, right? So it's the sandwich that needed protecting, not the worker. It was the sandwich that needed protecting. But when the worker put those gloves on and then touched all of the things, did they protect the sandwich? Okay, so let's change the sandwich name to patient. Does that make sense? So if you think of your patient like that sandwich, everything you touch is going to contaminate those gloves, which then contaminates the patient. Okay, so that's a very, very real issue in healthcare. Very real. People wear gloves when they don't need them. They wear gloves much too long. And one of my favorites is they put all of their gloves in their pocket and then walk in and out of all of those patient rooms. They put their hands in their pockets all the time to pull out pens. So by the time they grab a set of gloves out of their pocket to put them on, are those gloves still clean? No. Another one that you'll see is people wearing gloves outside of the patient room. If you've put gloves on in the patient's room, once you've touched things in that room, those gloves are, dirty. And if you're taking that patient's cooties on those gloves outside of the patient room, you're cross-contaminating. Does that make sense? Gloves should not, all the patient's cooties should stay with them or go down the drain in the sink. They shouldn't be exported. Does that make sense? And the problem is about 20 years ago, and this is why your brain thinks this way. About 20 years ago, we were training all healthcare workers to wear gloves for everything. 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 If you're going to chart, wear gloves. If you're going to be on the computer, wear gloves. If you're going to work with a patient, wear gloves. If you're going to get supplies, wear gloves. We taught people to wear gloves for everything. Well, in that case, those gloves are protecting the sandwich worker, not the sandwich. Does that make sense? Are you guys willing to eat that sandwich? What's your hesitation?
Because, like if you go in a subway, they are touching everything, even the register and money and everything, and then they go back and make the sandwich. So
Right.
I'm trying to get it straight in my head how that works, because then I'm going to eat the sandwich.
Okay, do you want to eat a sandwich that's been put together by gloves that have touched everything?
I know, but it happens.
Sure, it happens, absolutely. Unfortunately, they haven't sat in my class yet, but they will. They will. But you are healthy, okay? So if you eat that sandwich, right, not appetizing, right? We don't like the fact that they touched money and they touched other things, and we don't like that. But if you were to eat that sandwich, your immune system is healthy and will be able to overcome whatever it experiences. Is this patient's immune system the same as yours? What's wrong with their immune system? They're already sick enough to be in a facility. So you're not starting on even ground here, are you? Who's the one in this scenario that needs to be protected? The patient. Does that help you? Okay. So when it comes to gloves, we think those gloves are there primarily to protect us. That's not the case. Those gloves are there primarily to protect the patient. We are going to the sink. We are washing pathogens off of our hands before and after every skill. Every skill. Whether or not we wear gloves, we are washing our hands before and after every skill. So, if you are performing good hand hygiene before you do a skill and after you do a skill, and you're paying attention to where your hands are, you don't ever let them near your face, are you at risk? Right. It's got to have a doorway in. So if you're not at risk because you're doing good hand hygiene before and after every skill, if you're not at risk, then who are those gloves there to protect? The patient. And yet we get this wrong. Good. If you don't understand good infection control, you will put your patients at risk because you'll think about it backwards. You'll protect you. And I'm not saying that we shouldn't protect us. We should. We should protect us as well. That's why we're going to wear gloves if we're touching body fluids or personal skin or non-intact skin. We are going to protect ourselves. But we have to understand that the one at risk here is this guy, not this guy. So let me turn it around on you because we think about this from the healthcare person's point of view, right? The CNA, the nurse, right? We're thinking about it from our point of view. So let me turn this around on you. If you're the patient in the hospital and you know the guy next to you has MRSA, do you want that CNA that's working with you to put gloves on and touch stuff in between your beds and then touch you? Why? Yeah, it's a horrible infection that spreads very easily. Absolutely. And somebody just put you in the direct line of fire. But they wore gloves. Doesn't that make you feel better? That's right. That's right. Yep. And they get to go home at the end of the day. So we've got to start thinking about gloves a little bit differently. Does that make sense? Good. All right. Okay, we also learned about linen rules. Now, most of these are repeats of what we already know. Linens can't touch your uniform. You have to have clean hands to get your linens. Don't snap or shake those linens. And anything unused has to be discarded. So if we take an extra washcloth and don't use it, it's got to go in dirty linen. Don't leave it in the room for later. Don't put it back on the clean linen shelf. Good? Okay, and then we learned how to end. Yeah, we're going to learn the other two later today. Then we learn how to end every skill, and that's the closing. We want to make sure the patient is in a clean and safe environment. Clean and safe environment. So look around. Always leave your patient looking better than you found them. We want to make sure that bed is in the lowest position. Let me explain this real quick. We're going to talk about this a little more today, but I want to explain this real quick. When you go to bed at night, you sit on the edge of the bed, you swing your legs into bed, you go to sleep. You toss and you turn all night long. You don't stay in the same position. You get up out of bed and you're groggy. You are not awake yet. You get up out of bed, you swing your legs out, and you expect that floor to be right where you left it because it's never, ever moved. It's always been right where you left it. Always. Not a day in your life have you swung your legs out of bed and there was no floor right where you left it. But when we raise the bed, we have moved the floor. Your patient is not expecting that floor to be absent. They put their legs out of the bed. They expect the floor to be right where they left it, and it's not, but they're going to put their weight on their feet like it is. And what's going to happen? They're going to fall. High beds are a fall risk, not because we're afraid they're going to roll out of bed. It's because when they get out of bed, that floor had better be right where they left it. Otherwise, they're going to fall. Does that make sense? That's because beds in a home setting don't go up and down. We now have beds where the head of the bed will go up and down and the foot of the bed will go up and down like a hospital bed. But hospital beds are unique in that the entire bed goes up and down. And that's to make it easier for you to change the sheets or to work with the patient, right? We have entire beds that get raised for other people to do the work on you. Now at home, nobody else is doing the work on you. There's no reason to have a bed that raises up and down. So your beds at home don't do this. Your patient's bed at home doesn't do this. Only clinical beds do this. So don't expect your patient to know that the floor is not there. Good? Make sense? Everybody assumes that this is a fall risk because we think the patient's going to roll out of bed. That's not what this is. We'll talk about rolling later. We're going to ask them if they're comfortable. They need to hear this word. Are you comfortable? We're going to address emotional comfort as well by addressing preferences. Do you want the head of the bed up? Would you like a magazine? You know, we're going to just try to give them something to do. And we want to make sure they're covered. Sheet, fine. Clothing, fine. If they say, I don't want it, fine. But we're going to address it. I should not see knobby knees. Not for the test. Remember I said for the test, when you're the patient, you get a script? Yeah, you're just going to be pleasant, cooperative, and agree to everything. So somebody's going to ask, do you want the sheet back up? You're going to say, yeah. Good? Okay. We're going to open that privacy curtain. Now, the patient doesn't have to have it open. They can say, no, leave it closed, please. I want to take a nap. That would be me this morning. It was dark. It was rainy. I was ready to stay in bed, right? Leave that privacy curtain closed. I'm going to take a little snooze. It's fine. Who needs to know that? The nurse. That's right. That's right. So we're going to open the privacy curtain unless the patient instructs us otherwise. Why would we need to let the nurse know about that? Well, if the patient's sleeping more, it could indicate a change in medical condition. It could indicate depression. It could indicate a side effect of a medication that they're on. It could indicate boredom. It could indicate that they didn't sleep well last night because people were in the hallway kicking up such a ruckus that they couldn't sleep. Those are all things that the nurse probably needs to know. By the way, if you end up working nights, please don't be that caregiver. Nights means patients need to sleep. This is not the time for staff to be loud, yelling down hallways, having a party in the break room. We want to be like little mice, super quiet so our patients sleep, because people that are ill or injured need rest to recover. And I've been in way too many facilities where night shift is just as loud as day. How are we expecting our patients to rest and recover? So if you end up working nights, please keep this in mind. Okay, we need to give them their call light. They have to have a way of contacting us. Do you remember what I said about the call light? It is the only thing that sets that patient apart from being home. That's it. It is not the x-ray machine down the hall. We've got x-ray machines that we can get a patient to all over the county. It is not the lab. We've got labs all over the county. It is not the doctor. There's doctor's offices all over the county. It is not the IVs. We have nurses that go to patients' homes and give IVs. Those are not why they are in a facility. They are in a facility to be able to call when they need help and have somebody come immediately. That is what the call light is for. The call light is the one thing, the only thing that sets this setting up differently from other settings your patient might find themselves in. So don't hide the call light. Don't say things like they're abusing the call light. If you got a patient on the call light a lot, they've got an unmet need. You better figure out what it is. They've got an unmet need. It could be the need for attention. Certainly. That may be. It could be a need for attention, but it could also be the fact that they're scared or vulnerable or in pain. We have to know all these things. Once we're done with all of those things, then we're going to go wash our hands. Get rid of those cooties. Leave the patient's cooties behind. Once we have washed our hands, then we can document if necessary. Remember, there's 4 documentation skills: pulse, respirations, feeding, and drainage bag. You will get one of those 4 on the state exam. So you document after you wash your hands, and then you wash your hands again, because our cardinal rule here is end skill with clean hands. So at the beginning, we don't touch our patient until our hands are clean. And at the end, the very last thing we do is wash our hands. So when we're leaving the patient environment, we're not taking the patient's cooties with them. Now, I've seen this a lot too in the exam. People will go wash their hands and then they'll come over and hand the patient a light or straighten the sheet. What did you just do? Yeah, you re-cootied up. Absolutely. So the very last thing that you do is wash your hands. Always. If you have to give the patient the call light after you wash your hands, what would you do after giving them the call light? Wash your hands again. Remember, the patient's cooties have to stay with them. Good? Questions?
What if there's a sink in the room? Okay, you do all that stuff, and yeah, you wash your hands regularly. What if there is also the sterilizer hanging on the wall? Can you have the option to use the sterilization before you walk out the door?
So you're going to go by 2 things. The first is the policy and procedure of your facility. Okay. So we have to find out, what does our facility want us to do? Does our facility want us to wash our hands at the sink or use hand sanitizer? So that's number 1. Number 2 is, what does this care plan say about hand washing? Because if your patient has norovirus or C. diff, hand sanitizer is not effective. So even though we may have a policy and procedure, it says that we can use hand sanitizer if your hands are not visibly soiled. That is a very valid policy and procedure. Okay. But our care plan says for this patient, we must wash our hands with soap and water. So which one wins? The policy and procedure, hand sanitizer is okay, or the care plan? The care plan, because it's modifying the instructions for this patient. Does that make sense? Now, I'm going to throw you a different one. Let's say that we are working at a children's hospital. Little ones. So cute. Adorable. And we're working on the burn unit of a children's hospital. Our care plan won't specify. Our policy and procedure will. In burn units, there is a very high risk of infection, like 10 times the rate of the risk of infection as everybody else, because the biggest glove in the world is your skin, and that's been burned. So we've got a very high risk of infection. So the policy and procedure on that unit would be to wash your hands before every patient contact. If you're working in a chemotherapy unit, your policy and procedure is going to say to physically wash your hands because we've destroyed their immune system. We've killed it. If you're working with HIV positive patients, your care plan or your policy and procedure is going to be to wash your hands before and after every patient encounter. So a lot of what you're asking is going to depend on the patient population we're working with, as well as the specific needs of that patient. So 2 places that we go is the policy and procedure, which are global rules, and the care plan, which is an individual rule. Good. I can't give you one answer that's going to cover everything because every patient is going to require a different level of care from us. Good. Good. Okay. So let's talk about something that's very relevant to Florida right now. There is a bacterium that lives in warm, fresh water. And our water, Florida Peninsula, water everywhere, rivers, lakes, ponds. Our water is very warm. Anybody been outside? Our water is very warm. And this particular bacterium is proliferating. We actually just had our first death in Florida from this bacteria, and it enters the smallest cut. So if you're wading in the water and you've got a small mosquito bite on your foot that you just scratched until it was open, yeah, that's enough for this to get in. And it will often result in amputation of the limb, but sometimes results in death. And we just had our first death, and they just released a health alert about this, advising caution with any warm bodies of water. So if you are healthy and young, you're 26 and you went to the river with your friends and it was warm and you happen to get this infection and you are laying in the hospital praying, just praying that you get out with all of your extremities, just praying. And then somebody comes along and gives you something else to fight. How fair is that? You probably would have been safer at home, honestly. So we have to think about the real world consequences to our patients when we're going into healthcare. Does that make sense? Okay. So don't touch your patient until you've got clean hands, and make sure that you're cleaning your hands well before you leave that patient, because we don't want to take that to somebody else. Okay. There was a woman, this is an example I used to give years ago, so this is quite a while ago, but she went in for an MRI and accidentally scraped up against a piece of equipment in the MRI room while she was trying to get on the table, and just had a small scrape on her leg and ended up with an infection that caused an amputation just from having an MRI. And it wasn't even like a cut, it was a scrape. Just a little scratch. Guys, pathogens are in healthcare settings. That's where we take them on purpose. So we've got to get this right. Good. Yeah, it always makes me laugh, people that rush to health or to hospitals like ERs when they really don't need to be there. Do you know that is like, you won't catch me in the ER unless I'm absolutely certain that whatever I have can't wait until morning. If I think it can wait until morning and I can get into a walk-in clinic or a doctor's office, I'm going to hold off because I know what's in that setting. And I really don't want to be in the same place as those things when my immune system is depressed. So I'm not going to the ER for an earache. Chest pain, I'm there. Make sense? We don't really think about the different types of pathogens that might be in a clinical setting. All right, we learned how to wash our hands. So when we're washing our hands, we're going to wet the hands first. Well, you can turn the faucet on with your dirty hands, it's fine. Wet your hands, put some soap on. When you bring them together, that's when your time starts. And you have to rub for how long? 20 seconds. So that's the tops of the wrists, the backs of the hands in between your fingers, in between your thumb and index finger, the bottom of your hand by your pinky, the palm of your hand, all of those areas for at least 20 seconds. Should we sing? No, you should use the clock. Once you're done with that, you'll go down each one of your nails with your thumb to clean your cuticles. And then you'll circle your nails in the palm of your hand to clean underneath. And then you can rinse. After rinsing, tap to keep the water confined. Dry with however many paper towels you need. If you need 2, that's fine. If you need 10, use them. Dry your hands appropriately. Throw those away and then get a clean dry paper towel to turn the faucet off. But only dry what's clean. If you cleaned the tops of your wrists, but you splashed some water up here, don't take that paper towel and come up here. Did you clean up here? So if you pat dry up here and then you come back down here, what did we do? Recontaminated. All right. We learned how to take a pulse. Pulse is a measurement of how many times the heart beats over 1 minute. We're going to use the radial pulse located at the top of the thumb side of the wrist. We use 2 fingers, not our thumb. Never your thumb. Use your fingertips, not the flat part. Find the pulse. You look at the clock, pick a starting point, and say start out loud, because on the other side of the patient is the evaluator. They need to count while you're counting. So we're going to say start out loud. We're going to count for 1 full minute because that's what our care plan tells us to do. We're going to say stop at the end of that minute. We're going to do our closing, wash our hands, document, and wash our hands again. Good? We learned how to dress a resident with a weak arm. We want to ask them what they want to wear. We'll gather the clothing first so that we can reduce their exposure. You're going to lift from below with a flat palm. We undress strong or support all joints when lifting. We undress strong arm first, dress weak arm first. Make sure everything lines up. They look good at the end. Adjust clothing. Don't overextend or force movement. And the dirty items will go into the hamper. Does anything go on the floor? Nothing goes on the floor but shoes. Okay, nothing goes on the floor but shoes. So nothing clean, nothing dirty. So when you take that gown off the patient, don't throw it on the floor. Good? Nothing goes on the floor. And then the call light goes in the stronger hand. We learned how to do range of motion. This is the very last thing we learned how to do on Wednesday. CNAs do exercises to retain function, not regain. 2 totally different things. We're not trying to get anything better here. We're just trying to keep it from being degraded while they're recovering. So we lift extremities from below with a flat palm supporting at the joints. We've learned this already. Flexion extension is up, down. Abduction, adduction, side to side. Rotation, which you won't do on the test, is around. We follow the care plan. It'll tell us which joint, which side, which exercises, and how many repetitions. Along the way, we're going to monitor for pain. Ask them about pain, watch their face, Feel for resistance. We want to look for pain. And try to explain this in terms they can understand. Don't say, I'm going to move your shoulder in abduction and adduction. Those words are scary. People don't know what it means. And in healthcare, scary usually means pain. So your patient will stiffen up on you. They'll be cooperative, but they're going to be scared. So they'll be resistant. So instead of saying abduction, adduction, or in addition to saying abduction, adduction, I would say, I'm going to move your arm like you're making a snow angel. Patient's going to go, oh, I can do that. That's easy. That's not scary. Abduction, adduction, that's scary. You guys see the difference there? Work with your patient. A lot of times we try to make our patients feel like we know what we're doing by throwing out all these fancy terms and using medical abbreviations. And we think it's going to improve their confidence in us when actually it kind of does the opposite. It makes them afraid of us. We're no longer speaking the same language. Good. So if you look at all the principles up here, I told you that we were going to learn 11. This is class 3, and we have 4 principles to go. Look how many you've learned. Was it hard? Did I send you home and make you memorize all of this? No, we had to learn it. So we're going to learn the last 4. Not all of them today, though, in small bursts, okay? The first one that the first skill we're going to learn today is hand and nail care. This is going to be on page 116 of your book. Okay. So if we look down the side here, we can see all of the principles involved in this skill. They're all spelled out for us here. We've got our skill-specific steps that we'll go over in just a minute. We have our short version of the skill here. It does have a video. And then down here is our testing information. Somebody with your level of experience should be able to do this skill in 11 minutes or less. We're going to look at the care plan in just a minute, but we should be able to do this in 11 minutes or less. This is going to be done on another live testing student. So one of you guys might be a patient for hand and nail care, and that person will start the skill in a chair. So if you're practicing this at home or here in the classroom, you want a live person sitting in a chair for this skill. It is not a charting skill. No documentation required. Okay, so page 117 tells us our care plan and our step-by-step instructions along with our supplies. Look at those supplies. It's a lot to remember. Remember, the care plan is not going to tell you your supplies. You have to know them. I'm not going to say, hey, can you go do hand and nail care on that patient? And I want you to take a basin, soap, lotion, emery board, orange stick, 2 washcloths, and a towel. You'll also need a barrier to put all that on. I'm not going to do that. I'm going to assume that you know the supplies you need to do this particular skill. So you have to learn these. Let's take a look at that care plan. Remember that we do have flashcards that have the supplies. They're only $14.99. Okay, so let's take a look at this care plan. This care plan says provide hand and nail care to 1 hand. How many hands are we doing? What if they have 2? But what if they have 2? Good. Very good. We don't care. We don't care. Now, does this care plan tell you which hand to do? No. So for the test, you get to pick. You get to pick. Now, the reason there's a little bit of latitude here, let me explain this. The reason there's a little bit of latitude here is because this is done on a live testing student. We don't know who your patient's going to be. We have no idea. And if you have a brand new kitten at home you may have a scratch on one of your hands. And we don't want the CNA applicant to be doing hand and nail care on that hand. We're going to pick the best hand you've got. So the evaluator may indicate verbally which hand to do, but our care plan stays open to give us some options. Make sense? Good? Because we just don't know what your patient's going to be like. But let's talk about in a clinical setting. Very few times in a clinical setting will you ever have a care plan that only has you do hand and nail care on one hand. If the patient has two hands, we're probably doing both hands. Okay? But there are some situations where this might be a possibility. What if the patient has shingles and that rash is on their left arm? We don't want you doing hand and nail care on that hand. We don't want soap near it. We don't want lotion near that. Good? Make sense? What if the patient has a cast on an arm? What if a patient's arm is missing from amputation? There are situations where you may have a care plan that tells you to only do one hand. We're going to follow the care plan. So the patient is sitting in a chair at the side of the bed and can move as directed. So this is easy. Hand and nail care is a mini mani. We put a hand in a basin to soak. We take it out to wash it. We put it back in to rinse it. We take it out to dry it. We clean under the nails with an orange stick, and we file the rough edges with an emery board. Put some lotion on, wipe the lotion off, clean up. That's hand and nail care. You're going to wash, rinse, and dry the hand, clean under the nails, and file the edges. Now, the reason for this, pretty important actually, the reason for this is that CNAs do not trim nails. You do not use nail clippers. Do not use nail clippers. And if you are filing the nails on a regular basis, keeping them at a manageable length, you never have to clip them. Filing is preventative. Clipping is neglect and catch up. You guys see the difference there? Okay. Good? Good. Okay. So follow the care plan. But in order to do that, we have to learn two new principles today. Because we don't know these. We haven't learned these yet. So we're going to start with washing rules. The washing rules are on page 112. Ooh, the real faith. Good morning, Miss Patty. I passed my exam. Congratulations. I'm super, super proud. Congratulations. All right, so go to page 112 in your book, and it's going to show you, we're going to learn all this, okay, washing rules. It's going to show you the skills that we are going to apply this principle to. The notes are going to be on page 113. And to understand this, we have to understand washing rules. We kind of have to think a little bit about the way we bathe. Okay? You know what I don't have, Jake? I just realized. Hold on. Get me my iPad mic, please. Yeah.
Oh, I see.
Sorry, guys. I just realized this. I'm sorry. Okay. So we have to think a little bit about the way we bathe. So when we are bathing, we get undressed and we get into the shower, right? You get wet. You apply soap, shampoo your hair, whatever you're going to do. What's the next step? Rinsing. You would never just get out of the shower all soapy with shampoo in your hair. That would just be weird, wouldn't it? It would feel odd. Whatever you rinse, after you're done rinsing, you turn the water off and you dry. So this is a pretty simple process. We teach 5-year-olds can bathe themselves. You have to be careful because they'll make a mess, but they can still get the basics down, right? Whatever we wash, we rinse. Whatever we rinse, we dry. We know this. Seems very, very simple. And as long as you're doing it to you, you'll remember the steps. But when you're doing this to a patient, sometimes it's really easy to skip a step, particularly because most of the time the soap that we're using is not sudsy soap. It doesn't suds up so we can see the soap. There's a lot of formulas out there because we don't want to leave film on the patient's skin that can make them itch. So this becomes an issue. Whatever you wash, you rinse. Whatever you rinse, you dry. And you're going to hear me say this quite a bit. If you do this, if you say this in your mind while you're going through your steps, you won't forget one. But when we start practicing next week, if somebody does a washing skill, it's fun. You'll see it. Somebody will forget to do something. They will forget to rinse or they will forget to dry. It happens. So in your mind, I just want you to remember whatever I wash, I rinse. That way you know your next step. Whatever I rinse, I dry. That way you know the next step. Okay? All right. So because we have to have water to rinse with, if you're in the shower, we got water to rinse with, the water coming out of the shower head. But when we have a basin of water that we have brought over to the patient, we don't have running water. That basin has to be there for rinsing. If you add soap to that basin, you can't use it for rinsing. So we don't add soap to the water. We put the soap on the washcloth. Make sense? Then we wash whatever we need to wash, and now our water is still clean for rinsing. So because of that, basins are no soap zones. You don't put soap in the water. Now, some of you are going to say, but Miss Patty, you can get another basin. You can use 2 basins, one for washing, one for rinsing. And yeah, you can, but that's another thing you have to clean at the end. It's more time. But it's also another cost to the patient because these supplies are not free. Has anybody ever been a patient at a hospital? You get a bill. You get a bill. Healthcare is not free. You get a bill. Do you know what's on that bill? Every basin that somebody pulled out of a clean supply for you to use. Every toothbrush. Every bedpan that somebody threw away instead of cleaning. All of that is charged to you. And yeah, your insurance might pick up a little bit of it, but you're still responsible for some of it. So as CNAs, we have to understand that everything we get from our clean supply room is going to be charged to that patient. And these basins are about $38 a piece. $38 a piece. I can go to the Dollar Tree and get one for $1.25. Right? Think about it. We've got to be better than what we've seen happen out there. All right. So we're going to get water in our basin. Now, let's walk through this real quick. Okay. We've read our care plan. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do hand and nail care. Is that okay? I'm going to close your curtain, wash my hands. I have clean hands. And I'm going to go get my barrier, put it on the table, go get my supplies, put them on the barrier. And now I'm ready to get water because I have to fill my basin. I'm going to take my basin over to the sink. Now, I've washed my hands during the opening and all I've touched are clean things. Is that faucet clean? So can I touch that faucet with my clean hands? What could I use between my hands and the faucet? A paper towel. So we use a paper towel to turn the water on. And we're going to, remember your hands are clean. So we're going to use a paper towel to turn that faucet on, a barrier. Now, when we get the water running, we're going to feel it with the inside of our wrist, this area right here. It should feel warm, not hot, not cold, just warm, just warm. And we use the inside of our wrist because it's the most accurate temperature, not the back of your hand. This has fewer nerves, temperature sensing nerves, than this does. So the inside of your wrist. But just because I think it's comfortable doesn't mean my patient is going to agree. We all have different temperature preferences. I like my showers scalding hot. I want it to flay skin from my body. I want it scalding hot. My husband, on the other hand, likes cool showers. He works outside in the heat all day. He does not like hot showers. He wants cool showers. Everybody has a different preference. Don't assume your patient likes water temperature the same as you. So we're going to ask them, would you like to check the water temperature? But there's another reason for this, and it's physiological and age related. So let me explain the changes of aging with the skin. So when we're young, all of our layers here are nice and plump. We've got a nice plump skin layer. We've got a nice plump fat layer. We've got a nice plump muscle layer. It doesn't stay like that. As we age, those layers start to compress. And then when we get into older age, they actually start to dissolve. So do you see the difference between this fat layer and this fat layer? You guys are here. I want you to remember that. This is you. Okay? This is your patient. These are not the same. Now, what does that mean? Why should we care? Well, if you've ever looked at an older person's hands, right? Older person's hands, this is different than your hand. This, you can actually see the veins. They look like little road maps underneath the skin. There's not much between the skin and the bone. I mean, it's pretty thin, right? It's because these layers have shrunk. I'm actually getting there. I'm getting older. I'm actually getting there. You can see the changes of aging on the back of your hand. Well, why do we care? Let's talk about what that fat layer does. Anybody know what normal body temperature is? Okay, 98.6. Usually a range, 97.6, 99.6. We're just going to pick on 98.6. It's kind of universal normal body temp. Good? Everybody with me? What is room temperature where we're comfortable? Give me an example. Okay, let's go with 75. That's a nice, easy number, right? 75-degree room temperature, 98.6 body temperature. Those are not the same things. 98.6 is a whole lot more temperature than 75 room temperature. You guys got that? Big difference. Here's the problem. Room temperature always wins. Always wins. If you take a pie out of an oven, that pie has been baking at 325 degrees. You take it out of the oven and you set it on top, it's about 300 degrees. It's hot. You can't touch it. It's hot. Does that pie stay hot sitting on top of that oven? It cools off, and if you leave it there long enough, it will actually reach room temperature. Room temperature always wins. So something that started out 300 degrees is going to cool down to 75. Now, pie goes well with ice cream. So let's get some ice cream out of our freezer. That ice cream is about 0 degrees. It's frozen. We put it on our counter. If we leave it there, does it stay 0 degrees? It warms up to room temperature. Room temperature always wins. You guys understand that? Human body is 98.6 degrees. I just told you room temperature always wins. How do we stay at 98.6 degrees when room temperature is trying to get us to 75? How does that happen? It's a physiological response. Our body has to stay 98.6. In fact, it's so specific. Body temperature, human body temperature. 98.6 is normal. 100.5 is a fever. 2 degrees. 2 degrees. And it's a fever. 2 degrees the other way is hypothermia. Below about 95, you're in real trouble. Below 93, you're dead. Dead. Now, room temperature is 75. If room temperature gets you down to 93, it wins. So there has to be a way for us to keep ourselves at this temperature. Good? Got it? That way is a very active process called digestion, where we burn calories. Burning creates heat. Heat keeps our temperature where it's supposed to be. This is why you eat. You have to burn calories to generate heat to keep your body in a living state. Good? Make sense? That's a lot of work. Oh my gosh, that's a lot of work to go from 75 to 98.6. That's a lot of burning. So your body has a built-in mechanism to kind of help it out, a wetsuit. That layer of fat is a wetsuit. So when your body generates heat, that layer of fat keeps it inside, keeps it from radiating away. Does that make sense? So it helps maintain your temperature. Your body doesn't have to work so hard. It generates a little heat, fat keeps it in, we're happy. That fat layer, though, doesn't just keep the heat that you generate in, it also helps keep outside temperatures from cooling you down or making you hot. Otherwise, when you walked outside and it was 110 degrees, which was our feel-like temperature last week, your body would go up in temperature. And remember, anything over 100.5 is a fever. So we have to have a way of regulating this body temperature. Make sense? Good? That's what our fat layer does. It helps keep outside temperatures out, helps hold inside temperatures in, and keep us at a nice, steady 98.6 or in that normal range. So remember I said that as we age, that fat layer goes away. So if that fat layer goes away, let me go back here. If that fat layer goes away, oh, well, wait a minute. That means that outside temperatures are going to affect us and we're not going to hold our inside heat in better. So our normal temperatures for elderly are probably a little bit lower. Have you ever walked into grandma's house and you're like, oh my gosh, grandma, it's 88 degrees in here. It is hot. Let's turn the air on. And she's like, oh no, it's fine. Well, it may be fine to her because her body doesn't have to work as hard to maintain her temperature because that outside temperature is not affecting her quite as much. Make sense? This is why in a facility, your little old ladies are sitting there just shivering inside in a little pink sweater. And you're like, oh my gosh, Mildred, it's hot in here. Why are you cold? Well, she's cold because she's lost her fat layer. This is also why you will hear older people say, I can't live up north anymore. I can't take the cold. That's why everybody retires to Florida. Does that make sense? We've lost our fat layer. But this fat layer is also, because it allows outside temperatures to affect us, it also is going to affect how they perceive water temperature. So we are going to use the inside of our wrist. It should feel warm, not hot, not cold, just warm. But we also need to ask them to check the water temperature as well. Because just because we think it's okay doesn't mean that they're going to interpret the same way. Does that make sense? This is a graded checkpoint, guys. And this is a very seriously graded checkpoint. Good? Make sense? So anytime we're going to use water on a patient, we check it and then we ask them to check it. One of the, I've got a lot of stories here, but when I was working in a facility, I was at the nurse's station. It was like in the middle of 3 hallways. There were 3 hallways that extended off of it. And the nurse's station was in the middle. And I could hear screaming from down one hall. And it was coming from the shower room. So I ran down there thinking somebody fell or something. I opened the door and my glasses fog up. I can't see a thing. I'm like blind. And the patient was just screaming. And there's fog, mist everywhere, steam. And I run over and I hit the wall, the faucet, the sprayer, turn it off. I'm like, what's going on? What's going on? And I had to move my glasses so I could see what was happening. And the patient is in a shower chair, hitting and kicking and screaming, just screaming. And the CNA is trying to avoid the blows and push the patient under the water. Just push the shower chair under the water. And I'm like, stop. What is going on here? And the patient is crying. It's hot. It hurts. It's hot. And the CNA is yelling at her, it's not hot, it's fine. Does the CNA's opinion matter? She's not the one being bathed. Don't do that. Help isn't help if it doesn't help. And that certainly did not help that patient. Do you think that patient's going to be willing to get a shower after that? So the next person that comes in and says, hey, it's shower time. You ready to go? You know what she's going to say? Yep. Nope. So when you have a patient that's refusing care, understand that there may be a history there that you have no idea about. Does that make sense? Don't do that to people. These are people. Are you noticing in my instruction that the rules are one thing, right? But I'm teaching you what not to do out there as much as I am what to do. Do you know why that is? Do you know why I have to spend just as much time teaching you what not to do? Because it happens way more than you think it does. Way more. I honestly should probably be at about 70-30, 70% teaching you what not to do and 30% what to do. That's horrible. We can do better. We can be better. Because at some point in the very near future, I will probably need healthcare. So let's do better. All right. So whatever we wash, we rinse. Whatever we rinse, we dry. Rinsing is important. This is what soap looks like when it dries on the skin. It becomes itchy. It's irritating. Rinsing is a very, very important step. So we want to pay attention to the time this skill takes us, because if it takes too long and that water cools down, it can be uncomfortable for our patient. So change that water if it gets cold or if it gets soapy. Your basin should be on a barrier, particularly an absorbent barrier, so that the dry surfaces stay dry. But this also applies to the bed, because we're actually going to be learning how to give a bed bath later on in the program. And you don't want to get the sheets wet. Do you know how uncomfortable that would be for the patient to be laying on wet sheets after you're done? So we want to protect our surfaces, whether it's the table with a barrier or the bed with a towel or the floor for foot care. You want to protect your surface while you're doing washing skills. And then finally, if we're going to apply lotion, we warm that lotion up in our hands and then we put it on. Once it's on, though, your skin will only absorb so much, and then the layer gets saturated and everything else just kind of lays on the surface. It doesn't all get absorbed. So we put the lotion on and then we wipe off the excess. This is an important step, because if I put lotion on a hand and that lotion stays on the hand and that patient goes to pick up a cup of hot coffee, what's likely to happen? Yeah, the cup's going to spill. It'll slip out. Yep. Or we put lotion on the foot and we put that foot in a shoe. The foot can slide forward and cause the patient to stumble or fall or strain something. So when you use lotion, we put the lotion on, let it sit for a couple seconds, and then wipe the excess off. Good. So we've learned washing rules. Any questions on washing rules? We're going to put them into practice here in a minute. But before that, we have to learn basin cleaning. Basin cleaning is going to be used in a lot of skills. About half of our skills require us to clean something. The notes for this are going to be located on page 91. Basin cleaning looks a whole lot harder than it is. It looks a lot harder than it is. So for the test, I want you to understand, for the test, we are going to rinse it, dry it, and store it. That is what's required for the test. We rinse, we dry, we store. Good? Can you remember that? For the test, we rinse it, we dry it, we store it. I'm going to teach you a method that allows for disinfection during that process. Rinse, dry, store. I'm going to show you a way of doing that that allows you to disinfect in the middle of it and not cross-contaminate. So this one method will cover whether you have to disinfect or not. Now, it's important to understand that these basins that your patient uses are only theirs. They're not used from patient to patient. So when you get in the hospital, you get handed a bath basin, that is your bath basin. Nobody else is going to use it. Your bedpan is your bedpan. Nobody else is going to use it. Yours. Good? So rinsing, drying, and storing are fine because they belong to that patient. But there are situations where you will have to disinfect, particularly if we have a, yeah, no, I'm freezing up here. Particularly if we have a immune dysfunction of some sort. All right, so we're going to dump our basin wherever it would normally go. So if it's bathing water, it goes in the sink. If it's mouth care stuff, it goes in the sink. Anybody brush your teeth over the toilet? Because that would be like weird, right? If it's urine or feces or emesis, which is vomit, where does that normally go? In the toilet. So put it where it normally goes. There's nothing real important, put it where it normally goes. All right. Once you have dumped your basin, we have to rinse it. So we're going to go to the sink. We're going to get some water. We're going to rinse it. And I can touch that faucet, no problem. That faucet is dirty. My gloves are dirty. I've just worked with the patient. I'm working with some sort of body fluids or washing. I'm fine. I don't need a barrier here. Dirty can touch dirty. Clean cannot touch dirty. Clean requires a barrier. Good? Okay. So I'm going to rinse that basin, but I don't want to dump the rinse water in the sink if the contents went into the toilet. So if this held emesis, vomit, I don't want to dump vomit rinse water in the sink. I want to put the rinse water in the toilet. If I'm cleaning a bedpan that held urine, I want to rinse the bedpan and dump the rinse water in the toilet. Okay, so you rinse and dump that wherever the stuff went. Good? Questions? So we dump it wherever it normally goes, rinse it, dump that wherever the stuff went. Now, everybody good on that? Okay, now, I already talked to you about this. Now, if you have to disinfect, this is where it gets a little like, wait, stop. There's a lot going on here, okay? If you have to disinfect, you cannot be holding a basin with dirty gloves or a dirty hand while you're disinfecting. It's counterproductive. We have to set the basin down to disinfect it. Now for the test, we are not disinfecting anything. For the test, we are rinsing, drying, and storing. That's it. But if we do, in a clinical setting, have to disinfect, we're going to set that basin down in the sink. There we go. Okay, we're going to set it down in the sink and then disinfect it. Spray it, wash it, whatever our policy and procedure tells us to do. And then once we have disinfected it and we're ready to pick it up, can we pick up that now disinfected basin with our dirty gloves? So what could we use between our dirty gloves? A paper towel. So we can't touch it with our dirty gloves. We're going to use a paper towel between our gloves in that basin. Then we're going to use a paper towel to dry the inside. When we disinfect it, we only disinfect the inside. We didn't disinfect the outside. Don't need to. It didn't hold anything. Right? Didn't hold any infectious anything. So we disinfected the inside. We dry the inside with a paper towel. We're going to throw that away. We're going to use a different paper towel to dry the outside. We'll throw that away. And then I'm going to get another paper towel to open the drawer because my gloves are still dirty. Do I want to touch this drawer with dirty gloves when I know my patient can touch it later or family members can touch it later? Or I'm going to have to touch it later to get clean supplies? So that third paper towel opens the drawer. Good? So we dump it, we rinse it, we dump it, we set it down, we spray it. Paper towel to pick it up, paper towel to dry the inside, throw it away. Paper towel to dry the outside, throw it away. One more for the drawer. For the test, we rinse it, we dry it, we store it. Good? No disinfection. Okay. Don't worry if you don't get that all, right away. You're going to see this in about half of the skills. So you're going to see this about 10 times over and over and over and over. And by the end of the program, you'll have this down. Right now, I just want to do a brief overview. Good? Okay. So now we know all of the principles that we need. Now we need to learn our skills-specific steps. So the skills-specific steps here are going to, this is our checklist, okay? They're going to fill in the things that we don't have checked off. So we did our opening and got all of these green checks. We we used a barrier and got this checked. We used linen rules and got this checked off. And this, we decided if we needed gloves here. We used our washing rules and our basin cleaning rules, and we did our closing, and we've got all those things checked off. So these steps that we're about to go over are going to check off these things that haven't been checked off yet. But if you look at that, 3/4 of it have nothing to do with the skill. They're principles. 3/4 of this checklist isn't about the skill, it's about knowing the principles. Because those principles get applied to every skill. Good? Questions? Okay, so we're going to, our patient is sitting in a chair at the side of the bed. We've done our opening. We got our barrier. We filled our basin with water. We checked it. They checked it. All of those things. We are going to have our patient soak their hand in the basin. Once they've soaked their hand in the basin, then we're going to take it out. We're going to provide support as we move that hand, and we want to set it on a towel to the side of the basin. We have to wash, rinse, and dry. So we have our patient's hand on a towel to the side of the basin. We're going to get our washcloth, wring it out really well, apply soap to the washcloth, not the basin, the washcloth. We're going to wash the patient's hand. Set that washcloth aside. And then we're going to put the hand in the basin, hand in the basin to rinse it. Then we're going to put it back on that towel to dry it. Once we've washed, rinsed, and dried, now we're ready to clean under the nails. And to clean under the nails, we're going to use an orange stick. So this is an orange stick. It has a pointed end and it has a slanted end. The slanted end is the one that we're going to use, the slanted end. We're going to put it just under the edge of the nail, circle it around. Now it has debris. Do I want to take that debris and put it under the next nail? So I'm going to wipe it off on the towel that's right there and then clean under the next nail. Wipe that one, clean under the next nail. Wipe that one, clean, wipe, clean, wipe. Good? Then, once we've got the nails cleaned, we're going to take the emery board and we are going to, we're going to file in one direction toward the center. What we normally do, remember there's a difference between older patient skin and younger patient skin. Nails are the same. So with older patients, their nails can become very brittle. And if we take this emery board and we go back and forth across that nail like this really fast, like we normally do, it's pulling and pushing that nail right along the center ridge, which can cause that center ridge to split. And your patient's nails will open up like ladybug wings and fall off. Really painful. We don't want to split that nail down the center. So when we're working with patients, particularly elderly patients that may have brittle nails, we avoid that by filing in one direction only toward the center. From the outside to the center. I'll come over here, outside to the center. And then if it formed a point at the center, I can just go right across that center, not back and forth, one direction to knock that point down. Good? If you do this on a regular basis, you never, ever, ever have to trim nails. So hand and nail care is usually ordered once a week. Questions? After we have cleaned under the nails and filed the rough edges, then we can warm the lotion up in our hands. Oh, support the arm and wrist at all times. We're going to warm the lotion up in our hands, apply it to all surfaces, and then wipe that lotion off. Good? So now we have all of these principles that we have learned, that we know. So let's check off our checklist with those principles. So the first thing I'm going to do is read my care plan. Then I'm going to do my opening. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to do hand and nail care. Is that okay? I've asked if it's okay. I did not touch the patient. My hands are not clean. I announced myself and I did not call them honey and sweetie. I kept it professional. I got all of those things checked off. Once I get my okay, then I'm going to wash my hands and go get I'm going to decide if I need gloves. I'll take a look and see, do I need gloves? And then I'm going to go get a barrier for my table. I'll go get all of my supplies, not holding them against my uniform and not throwing anything on the floor. And then I'm going to follow my washing rules. I'll get water and check it. They're going to check it. Whatever I wash, I rinse. Whatever I rinse, I dry. I apply lotion last. Change the water if it gets cold or soapy. Once I'm done, I'm going to clean that basin like I clean all basins. And I'm going to do my skill-specific steps. But if you notice here, we've got very few skill-specific steps for this particular skill. We're going to clean under the nails. We're going to file in one direction. We're going to make sure the hand is on a towel so it's a softer surface. That's pretty much it. And then we're going to do our closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Here's your call light. Environment's clean, bed's in the low position. Open the curtain, go wash my hands. I'm going to read that care plan one more time just to make sure I did it right. And then I'll tell the evaluator my skill is done. Now, this care plan is only for this patient. It's not for these guys. This one, she goes to the salon. A lot of facilities have a salon right on site. She gets her nails done there. She doesn't have hand and nail care on her care plan. This guy has hand and nail care on his care plan, but he's ambulatory. He gets up and walks all by himself. So he washes his own hands. All we're going to be doing for him is filing and cleaning with an orange stick. This one, her family comes in and takes care of her. Does all of her hand and nail care. So all we're going to do is kind of take a look and see if everything looks good. Good? Everybody has a different care plan. All right, so I'm going to pass these around so you guys can see what an orange stick and an emery board look like. You can see the difference, the slanted end and the pointed end. Remember, we use the slanted end, so I'll pass this around while we're watching the movie. I'll show you this video because it has really good close-ups for you. And then once the video is over, I'll take questions and then we'll go on break.
Hello.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm good. How are you?
Fantastic. I need to perform hand and nail care on one hand. Is that okay?
Yes.
Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I can get my clean supplies. We're going to place a barrier on the table with the absorbent side facing up. This gives us a clean area for our clean supplies. And for this skill, I need a towel and 2 washcloths. We'll bring this over to the patient area. From our bedside cabinet, we'll get a basin, soap, and lotion, and an orange stick and emery board. We'll set these items on the over bed table. All right, Mr. Jones, I'm going to go get some water in the basin. I'm going to use a paper towel to turn the water on. Check the water temperature with the inside of my wrist. It should feel warm, not hot or cold, just warm. And we'll fill the basin about 1/4 of the way full. And then throw the paper towel away. Mr. Jones, would you like to check the water temperature? Is it comfortable?
Yes.
Can you submerge your left hand in the basin, please? Thank you. I'm going to put the washcloths in here. And we're going to rinse your hand using the first washcloth. And now I'm going to place your hand over here on the towel. I'm going to take the washcloth, wring it out really well, and apply soap. Now I'm going to wash all surfaces of the hand. The thumb, each finger, in between each finger, we'll clean the palm of the hand as well. and the webbing between the thumb and the index finger. I'll set that aside. Mr. Jones, we're going to put the hand back in the basin to rinse. And using the washcloth, we'll just squeeze water over the hand to rinse. I'm going to turn your hand over, and we'll rinse the palm as well. Okay. I'm going to lift your hand up and place it on this towel, and we'll dry your hand using the towel. We want to dry all surfaces. We'll go ahead and turn your hand over. Make sure that all surfaces are dry. And now we're going to clean your nails with our orange stick. We're going to use the beveled end of the orange stick. We're going to clean under each nail, circling it around and wiping it off on the towel in between each nail. So we'll clean under the nail and wipe. I'm going to repeat on all nails. And now that the nails are clean, we're going to use the emery board and file the rough edges. We always file in one direction toward the center. I'm going to repeat on all nails just to make sure that the nail edges are smooth and free of any rough edges that might accidentally harm the patient's skin. Once the nails have been filed, we'll get some lotion. And we're going to warm the lotion up in our hands before we apply it to the patient's skin. So I'll rub my hands together to warm that lotion, apply it to all surfaces, making sure to coat all of the skin surfaces. And then we'll take that towel and wipe off the excess lotion. That way, it's not a slipping hazard if there's any lotion left on the surface of the skin. Now I'm going to take your linens and place them in dirty linen. I'll be right back.
Okay.
And I'm going to go clean your basin. I'll be right back. I'll bring the basin of water to the sink, dispose of the water into the sink, and rinse the basin. We'll dispose of the rinse water into the sink as well. I'll set the basin down, disinfect it per facility policy, and then use a paper towel to pick it up. I'll dry the inside with a clean paper towel. Throw that paper towel away. Dry the outside with a clean paper towel and throw that paper towel away, and then get one for the drawer. On the way, we'll pick up the soap and the lotion with the paper towel, place them in the basin, and use the paper towel to open the drawer. We'll slide this basin, soap, and lotion in the drawer and close it with the paper towel. Now we can dispose of our disposables. So the emery board and the orange stick will go in the garbage along with the barrier. So we're just going to put these directly in the garbage can. Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. I'm just going to move this table out of your way. Here's your call light, Mr. Jones. If you need anything at all, please press the button and let us know. We'll be happy to come help. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. All right, any questions on that one?
When we're doing for the evaluator, we're gonna, like, everything we're doing, we're gonna announce out loud.
Great question. So, and I get this question a lot. Do I have to say everything you say, right, when I'm taking the test? And the answer is there's no checkpoint. We looked at the checkpoints. There are no checkpoints that says everything Miss Patty said. Okay. There is a checkpoint that specifically tells us to, hold on, let me read it rather than doing it from, provide explanations to resident about care before beginning. That's when we get consent, and during care. Okay. That's the only checkpoint here that they're grading you on what you're saying to the patient. So before beginning, that's when we get consent, and during care. So what do we have to do to meet that standard? Well, you can just say, I'm going to wash your hand. That's fine. But the problem is that your patient really doesn't know what that entails, what the steps are. So if you grab somebody and they don't know, are they supposed to put their hand in the basin or out of the basin? You're going to get some resistance from them. So explaining to them every step of the way what you're doing will help gain their cooperation. It's that simple. It also helps you during the test, because by saying the steps out loud, you won't forget as much. So it helps you, it helps them, but it also breaks the silence. It would be very weird, strange, uncomfortable. And I'm going to pick on you because you're right there. Okay. So let's pretend that I'm going to do range of motion on her right shoulder. Okay. Okay. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do some exercises on your right shoulder. Is that okay?
Yes.
Okay. I'm closing the curtain, washing my hands.
Right. So I see what you're saying. You're not talking. So yeah. Right.
Okay. Do you need anything else?
Right. I understand what you're saying now.
So it's weird. It's uncomfortable. It's creepy. You're touching another person and you're not talking to them. It's weird for them, right? Wasn't weird for me. I'm doing my skill. I'm fine, but it's weird for them. So should you talk to them while you're doing the skill? Yeah, you should. You should. Okay. And one of the examples I like to give is as a female, if you've ever had a female exam, they aren't quiet in there. They're yapping about the new movies coming out, what they did over the weekend. They're talking, because imagine how uncomfortable that would be. Right? So when we're doing pericare on a patient, we need to think about that. How uncomfortable would it be to have somebody in that area of your body, your most personal area, quiet? We should be talking. And if we don't have anything to talk about, steps are fine. Tell them what you're doing. Good? Does that help?
Definitely.
I have a whole animated lesson on that on my main website if you want to watch it. Let's go ahead and go on break. We're going to come back in 15 minutes. Thank you. All right. Moving on to our next skill, which is making an occupied bed. So down here, you see all of the principles involved. They're all spelled out for us here. Skill-specific steps, short version of the skill. Down here is our testing information. Somebody with your level of experience should be able to change sheets with somebody in the bed in 14 minutes or less. That is way more time than you need. It does not take 14 minutes to change an occupied bed. A live person will be in the bed, not a mannequin. And this is important because live people can move, mannequins don't. You want a person that can move. It makes it a little bit easier to do the skill. This is not a charting skill, so no documentation will be required on this skill. If we go to page 142, we can see our step-by-step instructions. Down here, we have our care plan at the top, which we're going to look at closely here in a minute. Right here, though, you see a box. It says clean rolls toward me, dirty rolls away. This is our principle that we have to learn. Down here are our supplies. We'll talk about that principle in just a minute. Down there are the supplies that you need for this skill. And here is our care plan. Change the top sheet, bottom sheet, and pillowcase while the resident remains in bed. That's it. Change top sheet, bottom sheet, pillowcase while the resident remains in bed. Says resident can roll and move as directed, but cannot get out of bed. So we can ask them, scoot toward me, roll on your side. They can do what we ask them to do during the test. They just can't get out of bed. Says a bedspread, blanket, draw sheet, or underpad is not required for this skill. I want you to remember that we follow the care plan, the whole care plan, and nothing but the care plan. So if your mind says, let me put an underpad on so I can show what I know. Let me get extra credit for putting a draw sheet under this patient. Are you going to get extra credit? No, in fact, you'll probably get a penalty because you did not follow the care plan. Good? Make sense? All right, so we have two things to learn on linen rules that I told you we were coming back to today. And then we have another principle to learn, scoot and roll. And we're going to go through this very, very quickly. Okay, but we've already learned all of the other linen rules. Linens can't touch your uniform. You have to have clean hands to get your linens. Don't snap or shake them. Anything you don't use goes in dirty linen. We know those. But right here, clean rolls toward you, dirty rolls away. This is how we change something from dirty to clean. And let me show you how this works. You will never get complete, very important that you understand this. You will never get complete separation between clean and dirty when there is a patient in the bed, right? Because the patient is not clean and they're still in bed. So when we have a patient, here he is. When I have a patient, this is my bed, this is my sheet, this is my patient. He is in the middle of the bed on a dirty sheet. I've got to change this sheet. I need to put a clean sheet on the bed. So this is my clean sheet. Good so far? Okay, so I'm going to take this dirty sheet under this patient and I am going to roll it toward the patient. Clean rolls toward me, dirty rolls away. So I am rolling this dirty sheet away from me. And I am going to tuck it underneath this patient. Good so far? So if you look at this, what is facing up is the underside of the sheet because I rolled it toward the patient. The underside of the sheet is what's up. Good? Now I'm going to take the clean sheet and I'm going to roll it toward me. Clean rolls toward me. Good. So what's facing up is the underside of the sheet. So this clean sheet goes underneath this dirty sheet roll. Good. Good. Then I have the patient roll on their side. I go around to the other side of the bed. We remove that dirty one and spread out that clean one. Questions?
What about the fact that you just put the clean sheet up against the dirty sheet? The underside of it's now dirty, right? Because the patient's in the bed, you have no other choice.
The patient is not clean.
Right.
The patient was laying on the dirty.
Okay.
The patient is laying on the clean.
Yeah.
It doesn't matter that the sheets are touching
Okay.
because the patient is going to lay on both.
Right. Okay.
Does that make sense? That's why I said you will never get a complete separation of
Right.
clean and dirty
Right.
when a patient is in bed. It's the best we can do, which is why the underside, not the part that was touching the patient, the underside of the sheet and the underside of the clean sheet are what's touching,
Okay.
not the part the patient's laying on. Okay, so we're minimizing transfer as much as possible.
Right.
Now, the next question that you're going to ask is what happens if that sheet is wet? Okay. So if I have a wet sheet under the patient and I roll it toward the patient because dirty rolls away. So I roll the wet sheet and I take my clean sheet and I roll it toward me. Well, if I put that clean sheet underneath that dirty sheet, it's going to get wet. So what is something absorbent and waterproof that I could maybe wrap this roll in? A barrier, chucks. So if I wrap a barrier around that roll and then take this clean sheet and put that underneath, I can change the sheets without them getting wet. Good? Make sense? Okay. So this is not a hard skill. It really isn't. It takes a little bit of practice to get good at it, but we're just changing the sheet. Basically one half of the bed at a time, and then we go to the other half and change that. So that's what this is showing you, okay? We're going to change the sheet on this side of the bed, and then we're going to come around, have the patient turn over, and we'll take the dirty one off and smooth the clean one out and secure it. And that way we have the patient on a clean sheet. Nothing goes on the floor, ever. No clean, no dirty, nothing on the floor but shoes. Good? Questions? Okay, so this is the problem with changing a bed in a clinical setting because you have habits that you aren't even aware you have. So at home, when you change your sheets at home, chances are you take the sheets off of your bed and you throw them on the floor. And then you put the clean sheets on, then you bundle up your dirty sheets and take them to the laundry room to wash them or whatever. But we are used to taking sheets from a bed and throwing them onto the floor. You wouldn't even think twice about it because that's what you do at home. Well, there's a problem because our principle is nothing can go on the floor. So what do? Well, in the testing center, you will have a hamper right beside the bed or at the end of the bed. It'll be there. You don't have to worry about it. But in a clinical setting, we don't have hampers in the room. We don't keep dirty things in clinical settings. So clinical setting hampers look like this, and they're usually in the hallway. We don't want to be walking back and forth from hallway to room with all these sheets. So what we're going to do is put a chucks on the floor to put those sheets on. So you put the chucks on the floor, and then you can put the sheet on the chucks. That's fine. Or we're going to use a soiled linen bag. These are on a roll in your supply room. Go get a soiled linen bag, open it up, and put the sheets directly in there as you take them off the bed. These are like the original Tide Pods. We've been using these for years and years and years and years, way before Tide Pods were a thing. These bags actually have the soap impregnated in the bag. So the whole thing goes in the washer. Nobody takes these sheets out and shakes them out to make sure there's no hearing aids or earrings or dentures or pens. Or if it's in the bag, it's going in the laundry. So you have to, as a CNA, make sure that there's no foreign objects in the bag. Okay, good. Questions? Just don't put the sheets directly on the floor. We have a special room in most clinical settings called soiled utility, and this is where all of our soiled things go. If it's dirty, it goes into soiled utility, and a lot of times that's where your hamper will be located. All right, so with linens, you use it or you lose it. We've talked about this. You use it or you put it in dirty linen. So now we know all of linen rules. Let's move to scoot and roll. And I'm going to go through this very quickly. We're going to cover it again a little bit later on in the program. But very quickly, your person that you're working with does not need side rails to keep them safe in bed in most cases. We learn to sleep in a bed when we're about 2 or 3 years old. That's a skill we learn very early. And skills we learn very early in life stick with us throughout our entire life. And we're going to talk about that a little bit more on Wednesday morning. But skills that we learn early stick with us. So think about a newborn baby. We put them in a crib. But they only stay in a crib until they start to climb out of the crib. And when they start to climb out of a crib, now they're in danger of falling and getting injured. So that very crib that kept them safe when they were not mobile is the thing that gets them in trouble when they are mobile. Do you guys understand that principle? Same thing with this thing. Okay. If your patient is mobile, side rails make them fall from a higher height. Because if you put a adult patient in a bed with side rails up and tell them to stay, some of them are going to get out just because you told them to stay. I'm one of those. Tell me what to do. Go ahead. I have been independent since I was 3. You don't get, who do you think you are to tell me what to do? You really think that you're smarter than me? Right? I'm going to give you some attitude over that. You don't get to make that decision for me. So you put side rails up on my bed, it's on. I'm going to find a way out of this. I'm going to go over it, under it, around it, through it, but this is not going to keep me where you want me kept just because it's convenient for you. Does that make sense? So we have to be careful when we're using side rails. They aren't used for our convenience, but I hear this a lot. Well, my patient is weak and they're a fall risk. And if they get up out of bed and they're weak, they're likely to fall. So I'm going to put the side rails up to remind them that they can't get up out of bed. So in healthcare, we do things that make patients better, right? We're trying to improve their condition. Well, if I have a weak patient and I put them in bed and I put the side rails up, how did that improve their condition? Did it make them stronger? No. In fact, getting up frequently and walking them would make them stronger. It would improve their strength, their stamina, their balance. It would improve their overall, their circulation, the digestion, all of that. It would improve their overall being. So by putting a patient in bed and putting side rails up, that's helping you. It does not help the patient. Sure, we might have prevented a fall. They're not up roaming by themselves, but we've made them weaker, which means the next time we get them out of bed, what are they more likely to do? Fall. Or if they hit the call light, and this is what happens most often, they hit the call light and they wait. They know they're fall risk. You've drilled it into their heads. They're fall risk. They don't want to get up and wander around on their own because they're afraid you're going to lecture them. So they wait and 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 they've got to pee. And they wait and they wait and nobody comes. Well, at some point, they're faced with a choice. I can either get over that side rail and go to the bathroom, or I can pee the bed. Which one do you think they're going to do? Oh, yeah, they're not peeing in the bed. That's a dignity issue. They're not going to pee in the bed just because you didn't answer the call light. They're going over that. And what we've done is just put an obstacle in their way that's going to make it much more likely for them to fall. So side rails, because of all these issues, require a doctor's order. CNAs are not allowed to use side rails without a doctor's order. Not a nurse, a doctor. This is actually a legal principle, and it has to do with bodily autonomy. And a lot of people don't really realize the legal principle here. But there's only two types of people, two jobs that can interfere with your freedom of movement legally. There's only two, and both of those are temporary. There's only one that can do it permanently. A police officer can put you under arrest and interfere with your freedom of movement temporarily. Who do you have to see when you're arrested? A judge. A judge is the only one that can do it on a long-term basis. That's how serious your right to bodily autonomy is. There's only one. A police officer can put you under arrest for a short amount of time, but then you have to go before a judge, right? That's those are our rights. You have to go before a judge to make a determination of how long they're going to restrict you. The other one is a doctor. Notice that CNA was not on that list. Nurses, not on that list. Doctor, police. Both of those are temporary. Both of them require a judge to make it longer term. You see how serious side rails are? Okay. Side rails are basically the adult equivalent of a crib. When you put side rails up, it just makes it more likely that they're going to get injured when they try to get out. You don't need side rails to keep a patient safe. It's not most people. So when you started crawling out of your crib, let me go through this real quick. You started crawling out of your crib about 1.5 years old, maybe 2, depending. And mom took the crib away and put you in a toddler bed. Everybody remember toddler beds? They're really low to the ground, right? Really, really close to the ground. And then if mom liked you, she put something soft on the floor, right? And that way, because your body has to learn how to sleep in that bed. And you do. You might fall out once or twice onto that soft blanket or whatever, but you figure it out, that kindergarten mat. You figure it out and you start sleeping in the bed. Now, it's not, you don't fall out of the bed because it's your bed. I guarantee you've probably slept in other beds, like hotels, Airbnbs, friends' houses, right? You've slept in other beds. You don't fall out of those beds. And you've probably even napped on your couch and didn't fall off of that either. You're sound asleep and you're not falling off of your surface. So how does that happen? That's because at about 1.5 years to 2 years old, we learn something called spatial awareness. A little part of our brain is always awake and it keeps track of where we are in the space that we have to work with. That little part of the brain always awake, even when you're sleeping. And it'll make sure that as you roll over and as you stretch and you turn, you're not falling out of the bed. Now, there are two things that put that little part of the brain to sleep. Alcohol. This is why we can start out on a bar stool and then they get really tricky to navigate after a few drinks, right? Because spatial awareness is affected. And some medications can affect us. So that's up to the nurse to assess the patient, get in contact with the doctor if they think this is going to be a problem and work up a plan. Make sense? Good. So patients on their own, unless they have some reason, should be able to sleep in this bed without any side rails whatsoever. They're an adult. They've learned spatial awareness. They've got it down. They don't need your help. So we don't use side rails to keep people in bed just as a course of action. Good? Good. This is why side rails are dangerous. They actually increase the risk of injury. Hundreds of people get killed by side rails every year. They try to get out and they get caught. Strangulation.
Wow.
Mm-hmm. Yeah. Side rails are dangerous, guys. If we have side rails on, they count as a restraint, which means we have to physically go in and eyeball them every 15 minutes. Every 15 minutes. A lot of places don't use side rails anymore because of the risk of lawsuits. They hire sitters. Now, this is something that you guys are all eligible for. Go onto any hospital website, look for a patient safety attendant, also known as a sitter, and all of you guys are eligible for that position. You literally are hired to sit at the bedside and just notify somebody if the patient tries to get up. That's your job. You know, talk to them, entertain them, but that's your job, is to make sure they're not walking unaccompanied. So we'd rather have a person there than side rails because a person is safer. Good. Those of you who are going to nursing school, that is a fantastic job because you can take your textbooks in and study while you're sitting there. Fantastic job. All right, side rails actually make people weaker. Half rails are different. Now, half rails, these are not considered side rails. They're considered positioning rails because your patient can still swing their legs out and get up and move around unimpeded. So half rails, just at the top, those are not side rails. These, if you raise them, those are side rails. Good. We don't need side rails as long as patient's in the middle of the bed, what we call the safe zone, they're safe. So our job is to make sure your patient is always in the middle of the bed. If we're turning them, we need them in the middle of the bed after the turn. If we don't have them in the middle of the bed, see how close he is to the edge of the bed? How comfortable do you think he is? How safe do you think he feels? Yeah, that's scary. They're like super close to the edge. Even if a side rail was up on that side, do you think they feel safe being that close to the edge? No, side rails fail. There's a video going around on Facebook. I saw it about 2 weeks ago. A video of a family member took it. A patient was rolled right up against the side rail. So they're literally pressed up against the side rail and the side rail failed and the patient fell. Yeah. It's going, you probably can find it on Facebook somewhere. So this is not safe, guys. So if we're going to turn a patient onto their side, they need to be in the middle of the bed after the turn. Now, you do this automatically without thinking about it. If I put you in this bed, on your back in the middle of the bed, and told you to roll so you're facing that direction, you would not roll. You would shift. You pick your bottom up and scoot it so that after the roll, you're facing that direction, but you're still in the middle of the bed. We do this without thinking about it. Even if I said roll, you don't roll, you shift, right? Because your body knows it needs to be in the middle of the bed to be safe. So if we're going to turn somebody, if they're not turning themselves, if we are going to do the turning, we have to remember that principle. They need to be in the middle of the bed after the turn. So you ask them to scoot towards you, or you use a draw sheet, or you move them in segments, but you get them closer to you on the edge of the bed while they're on their back. And then we roll them onto their side. So scoot and roll. And then they're on their side in the middle of the bed. So if the patient is going to do it all on their own, just tell them to roll. If we have to get involved, it's scoot and then roll. Now, when you're rolling a patient, we roll them away from us, always away from us. Now, that's because we want to remain behind the patient's behind. You never want to roll a patient towards you. Weight distribution along their back will pull them back onto their back. That's way too far away from you to be able to control that. You want to turn them away from you so you're aware their weight is distributed. But there's also another reason. You never want to turn a patient so they're eye level with your crotch. No other way to say that. So remain behind the patient's behind. Patient must always be in the middle of the bed. Okay? So that's another principle down. So if you're keeping track, we now know 10 of our 11 principles. And it's only class 3. We're doing good. All right. So let's talk a little bit about the bed. So the head of the bed can go up and down. The foot of the bed can go up and down in a clinical setting and in some home settings. But in a clinical setting, the entire bed can go up and down. We talked about this a little bit this morning. Clinical settings are the only setting that has this ability. If we raise the entire bed to make it easier to change the sheets, you can do that. That's fine. This bed does it. There's a crank at the bottom of the bed. Just crank it and the whole bed will raise up. Fine, no problem. If you want to do that, go for it. But if you do not lower the bed at the end, if you leave it in this position, it doesn't matter how well you made that bed, it's an automatic failure. Because when this patient tries to get out of the bed, they're likely to fall. Okay? So you can raise the bed up if you want during the test. You will not see me do it for 2 reasons. Number 1, it's not a graded checkpoint. Number 2, I'm short. I don't need to. Most everybody is taller than me. So you may find that you need to raise the bed. So patients should never be placed on a bare mattress. We're going to remove and replace one side at a time. So we'll roll the dirty toward the patient, roll the clean toward us. If I just kind of levitated the patient, you can see I've got the clean sheet rolled underneath the dirty. That's how we're doing this. Now, time out here for a second. This care plan tells us our patient can't get out of bed, right? That we have to change the sheets with the patient in bed. If you ever walk by a bed and there's no patient in it, that's a great time to change those sheets. So if the patient is in a test, if they're in the shower room, if you see an empty bed, your brain should automatically go, wait, does that bed need to be changed? Let me get on that while there's no... I can change an unoccupied bed in about 90 seconds. A minute and a half. If I didn't have this mannequin in here, I could take all of the sheets off, put new sheets on in about a minute and a half.
But then are you doing something that's not set on the care plan?
Well, okay, so again, we want to go to the nurse and just ask,
Okay.
Can I change those sheets?
Okay.
And chances are she's going to tell you anytime we have a bed-bound patient, you don't need my permission. Anytime, check with her first, but
Okay.
she'll probably tell you anytime we have a bed-bound patient that is out of bed for something, change those sheets.
Okay.
And the reason is it's less stress on the patient. Your bed-bound patients, this is a lot of energy to scoot them towards you, to roll them up on their side. That energy could be going to healing. So if they're already out of bed and we can save some energy a little bit later, let's do that. So yeah, check with the nurse to make sure. But yes, they'll tell you, change it. All right. We'll secure all 4 corners once we have that clean sheet on, making sure that we reduce the wrinkles. Wrinkles contribute to bed sores. We'll talk about that next class. And then we're going to put the top sheet on and make hospital corners. Hospital corners are not hard, guys. They're not grading you on how pretty they look. You can see my hospital corners here. All it is doing is getting the corners of the sheet off the floor. Remember, nothing touches the floor. So if you don't know how to make good hospital corners, I'm going to show you in the video. If you can't get good hospital corners, just get the corners of the sheets underneath the mattress. That will work. It's the corners of the sheets that we don't want on the floor. But you really should know how to make a good hospital bed if you're going to be working in healthcare. This is something you probably need to learn. Once we get that sheet secured, we want to loosen it over the toes so they have a little wiggle room. We'll replace the pillowcase last. That limits the amount of time that they are without a pillow. Being on a bed without a pillow is very hard on the back, the neck. And for those of you who are thinking infection control, it's okay to have that pillow, dirty pillow, on the clean sheet because the dirty patient is on the clean sheet. Perfectly okay. Own cooties, that's right. Own germ bubble. So that pillowcase will be changed last. You want to limit the amount of time they are without that pillow. Okay. So now we know everything we need to know to do this skill. Let's take a look at the checklist, big checklist. We're going to do we're going to follow our care plan. We're going to do our opening. We're going to evaluate if we need gloves. Let's time out here for a second. For the test, you are performing this skill on another testing student, okay? So let's say that you have this skill. She is your patient. She is fully dressed. She is holding onto all of her own body fluids like a champ. She has no open sores. So to change a bed with her in it, you don't need gloves. Now, if this were your patient and she's wearing just a hospital gown and leaking everything, do you need gloves? Yes. So this isn't based on the skill, it's based on the patient. And the patient for the test, fully clothed, holding on to everything. We're going to use a barrier. We're going to use a privacy blanket for this because we have to take the sheet away. We're going to follow our linen rules, nothing on the floor, nothing held against us. We're going to keep the patient in the middle of the bed throughout the entire skill. And we're going to follow all of those steps that we just learned. Now, if you look at this checklist, you can see there's a lot of skill-specific steps here. This is the first skill where like half of our checklist is skill-specific. So these are steps that you're not going to see in other skills. These are, steps that are just for this particular skill. Then we'll do our closing at the end to wrap it up. Good? This care plan is only for this patient, not for these guys. This one gets out of bed. We're never changing an occupied bed. This one goes to the shower room twice a week on a stretcher. We change his sheets while he's out of bed in the shower room. And this one, let's say that for this skill, another shift is responsible for changing his sheets. Evening shift. So every patient's care plan is going to be a little different. Good? Let's go ahead and watch the video. Oops.
Hello.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I'd like to change your sheets. Is that okay?
Yes.
Let me close your curtain, wash my hands, get my supplies, and I'll be right back. After washing my hands, I'll get the supplies I need for this skill. So we're going to start with a barrier, putting it on the overbed table. This gives us a clean place to put our clean supplies. And then to make a bed, we're going to need a pillowcase, a top sheet, a bottom sheet, and a privacy blanket. We're going to start with the bottom sheet. So I'm going to place a privacy blanket over you. This is going to help keep you warm and provide some privacy as we do this skill. So I'll spread this out, being careful not to shake it or snap it, and lay it in place. I'm going to pull your top sheet all the way down, and we'll remove it from the bed. Wrapping it in a ball so that the trailing edges don't contaminate other surfaces. We're going to lay this on an unused part of the barrier on the table. Mr. Jones, can you scoot your whole body toward me? And then I'm going to ask you to roll to that side so you're in the middle of the bed. Thank you. We're going to remove the sheet, from the top and the bottom of the bed. And we'll roll this toward the patient. Dirty always rolls toward the patient. And we're going to tuck this in under the patient's body, all along the length of their body. Now we'll take the clean sheet, unfold it, and spread it out on the mattress, being careful not to shake it or snap it or let it touch the floor. We'll secure the corners. And then we'll take the clean sheet and roll it toward us to minimize wrinkles. And then we're going to lift the bottom sheet and tuck this clean sheet underneath the bottom sheet, all along the length of the body. So we'll roll it toward us. And then tuck it underneath the soiled sheet. You want to minimize the wrinkles that are under the patient. All right, Mr. Jones, can you come back onto your back and scoot to the middle? You'll feel a big roll. Okay, I'm going to go to the other side of the bed now. Can you scoot toward me, please? And then roll on your side so you're facing that direction. Thank you. We're going to remove the bottom sheet from the bed, rolling it in a ball. And then we'll place this with our other soiled items on the overbed table. We'll stretch out the clean sheet. Attach the corners. Minimizing the wrinkles underneath the patient. Okay, Mr. Jones, can you come back onto your back and scoot to the middle, please? Okay. Now we'll put the top sheet on. We want to open this up and spread it out, being careful not to snap it or shake it. We'll lay this over the patient. Making sure that there's an equal amount of sheet on each side of the bed. And then we're going to tuck the sheet under the mattress. So we'll lift the mattress and pull the sheet so that it's flat under the mattress. We're going to come down about a foot from the end of the bed, pick it straight up. You'll see a triangle here, and tuck in the bottom. We're going to lift the mattress from below, tuck the sheet so that it's flat under the mattress. Come down about a foot from the end of the bed, pick the top flap straight up. You'll see a triangle. Tuck everything else in. We're going to loosen this over the toes. And now I can remove your privacy blanket. I'm going to roll this into a ball and place it with our other dirty items. Mr. Jones, can I take your pillow? I'll bring it right back. We'll remove the pillowcase by holding the pillow and sliding the pillowcase down. We're going to place this with our other soiled items and put the pillow on the table. We'll take the pillowcase, scrunch it all the way up to the corners, and the tag side of the pillow will go into the pillowcase. So we'll stand it up, slide the pillowcase over the pillow, hold the whole pillow and pillowcase, and slide the sides down. The opening of the pillowcase is going to face away from the door. Mr. Jones, can you lift your head up for me? Thank you very much. Are you comfortable?
Yes.
Let me dispose of my supplies and I'll be right back. These are going to go into dirty linen. And then we'll dispose of our barrier. We'll place our table back and make sure our environment is clean. All right, Mr. Jones, is there anything else I can help you with?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Okay, your call light is right here. If you need anything, just press that red button. We'll be happy to help you.
Thank you.
Bed is in the low position. Environment is clean. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Any questions?
So if you were, for example, you have an elderly patient that has like neck issues and she can't lay her head all the way back and remove the pillow, are you able to like think ahead of time and grab another pillow to that way she doesn't have to strain her neck that much?
Right, and that would be in the care plan, is that basically we're going to switch the pillows out. She'll have two pillows, one on the bed. We'll put a clean pillowcase on the second one, switch the pillows out, and then that one would become the backup for the next switch. Okay, great point. Yeah, we have a solution for every problem. We just need to know there's a problem. Yeah. All right, last skill before we get into blood pressure. This is another range of motion. You guys remember the range of motion we learned? Right? So this is range of motion, elbow and wrist. So we learned the shoulder. Now we're going to learn elbow and wrist. So our principles are here. They're all spelled out for us here. Skill-specific steps are here. Down here is our testing information. Somebody with your level of experience, which is none, should be able to do this in 4 minutes or less. Page 79 has our step-by-step instructions along with our care plan at the top. There's no supplies for this skill. And here's our care plan. Provide the following range of motion exercise to the resident's right elbow and right wrist. Flexion extension. Do you guys remember what flexion extension was? Up, down. So move the elbow up, down. Move the wrist up, down. Put an opening in front. Put a closing in back. That's a skill. That's it. Now, how many times do we need to move the wrist up and down? Why? Yeah, because that's what care plan says. So our care plan is nothing more than our recipe. Tells us what body part, what exercise, and how many repetitions. So this is the easiest skill there is on the state exam. The easiest. We already know everything we need to know to do it. Let's review range of motion steps. Care plan is going to tell us which body part, what exercises, and the number of repetitions. We always support near the joints. Lift from below with a flat palm. Move slowly and smoothly. Return all the way to the start position. So elbow is going to be first. Okay. Up, down. So up, down, up, down, up, down. I'm moving slowly. I'm moving smoothly, and I'm going all the way to start. This is not a range of motion. It's got to go all the way back to start. Okay. Flexion extension is up, down. Abduction, adduction is side to side, not on this care plan. Rotation is around, not on this care plan. We're going to monitor for pain. That's it. That's it. That's the skill. Nothing more to tell you. Boy, what if they were all this easy? All right, let's use those principles to check off this checklist. We're going to do read our care plan. We're going to do our opening. We'll evaluate if we need gloves. If my patient is leaking body fluids, and I'm going to be near that, should I wear gloves? If my patient has an incision or a rash or a wound on the arm I'm going to be working on, do I need gloves? Yes. Before the test, it's another testing student, one of you guys. You're fully clothed, holding on to all of your own body fluids. So chances are you won't need gloves for this skill for the test. We're going to do our test-specific steps, and then we're going to end it with the closing, and we'll get all of our checkpoints. This care plan is only for this patient. This one is going to get abduction and adduction too of the wrist. This one doesn't get range of motion. He does everything on his own. He's just here for blood pressure. We don't need to do range of motion on him at all. And this one goes to physical therapy. So this care plan is only for this patient. Nobody else. Everybody gets their own care plan. Are you guys getting that concept? That we're not going to do this the exact same way on every single patient we care for? Good. All right, so we're going to watch this video. It takes like 2 minutes. As we're watching this video, Jake's going to be passing out cans and blood pressure kits because we're going to run into blood pressure next. So he'll be walking around as the video is playing. But like I said, the video is like 2 minutes long.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to do some exercises on your right elbow and wrist. Is that okay?
Yes.
Let me close your privacy curtain. I'm going to go wash my hands, get my supplies. I'll be right back. Okay, now that I've washed my hands, I'm going to have you extend your arm out, palm up. I'm going to do all the exercises. All you have to do is let me know if there's any pain or discomfort. I'm going to bend your wrist up towards your shoulder like you're making a muscle, and we'll do this 3 times. So all the way up and all the way back to start. Up and all the way back to start. Feel okay?
Yes.
One more. Up and all the way back to start, making sure the elbow is on the bed. Now we're going to move on to the wrist. We're going to move the hand up and down like you're revving a motorcycle, so light fist. You'll feel a little stretch. Let me know if there's any pain. We're going to go forward and back. Feel okay?
Yes.
Again, forward and back. Still good?
Yes.
One more. Forward and back. Okay?
Yes.
Very good. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Here's the call light. If you need anything at all, press that red button. We'll be happy to come help.
All right.
Your environment is clean. Bed is in low position. We'll go ahead and open the curtain, and I'll go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. See, quick. I would want that skill. I would want that skill. All right, so we're going to completely change gears now and go to blood pressure. So this is going to be on page 56 of your book, but I want you to notice what the title of this says, non-tested skills. That means that you will not have to demonstrate blood pressure on the state exam. Not with a manual cuff, not with an automated cuff. This is not a skill that is going to be performed by you on the test. That doesn't mean you don't need to know how to do it. Okay, everybody needs to know how to take a blood pressure. Please bear in mind that if you move to another state, there are states that restrict CNA's ability to take a blood pressure. Some states say, nope, we're not going to let our CNAs do this because we make medication changes based on the readings that you give us. And unfortunately, a lot of CNAs just pull numbers out of thin air. Yeah. It's sad. It's sad. People make up numbers for this all the time. So we don't want to be making medication changes on improper information. So in Florida, CNAs are allowed to take blood pressures, but it will depend on your facility, your policies and procedures as to who takes blood pressures wherever you go to work. In some places, CNAs can take screening blood pressures, which means you're just, basically everybody on the hallway is getting their blood pressure today. We're just looking for a problem. That's different from medication-related vital signs. Those have to be done by nurses in some settings. Good? Make sense? Good. And I'm actually in favor of that. I have a health condition that causes my blood pressure to spike periodically. And when I say spike, I mean sky high, really, really high. And it's a known condition. We know that I have it. We know how it has to be managed, but I was out of medication and I knew my blood pressure was high. I'd already checked it. I'd had it verified. I made an appointment, got in to see the doctor, and the medical assistant pumped it up. And the needle went, woo, and I'm going to explain that in a minute, but just went, woo, and said, oh, your blood pressure's fine. It's like 110/70. No, it's not. It's not. And when the doctor came in, I asked the doctor to recheck it. And he looked at the chart and he says, your blood pressure's fine. I said, no, I want you to check it. So he checked it and I was at like 260/180. Yeah. So if the doctor had just gone by what was on my chart and sent me home, I could have had a stroke. So this is one of those situations where it's really important that we get this right. And my blood pressure does spike like that every so often. And I have to take a medication when it happens. So it's probably a good thing, to have an accurate reading. So this is not a tested skill, but I do want you to understand what a blood pressure is. So what are we measuring here? Remember with pulse, we counted the thumps. You guys remember this graphic, right? We counted the thumps, right? So 1, 2, 3, 4, as we felt them go under our, that told us how much that heart beat, how often, what the rate was. Blood pressure is testing something different. Inside this artery, think of it like a hose, okay? Inside that artery, when that wave is moving through, there's higher pressure there. There's more blood right there. In between the waves, less blood, less pressure. What I want to know is how much pressure is when a wave is going through inside that artery, and how much pressure is when a wave is in between waves, when the heart is at rest. How much pressure is inside the artery then? That is the top number of your blood pressure and the bottom number of your blood pressure. So when a wave is moving through, that is your systolic or top number of your blood pressure. In between the waves, where there's less pressure, that is diastolic or the bottom number. Good? Normal values. Top number, systolic, should be between 100 and 119 to be normal. So between 100 and 119 is considered normal. It's a very narrow range, by the way. 100 to 119 is considered normal. Bottom number, 60 to 79 is considered normal. If either one of those is not in normal range, it must be reported to the nurse. So it doesn't take both of them to be out of normal range to be reported. If only one of them is out of range, it needs to be reported. So if I have a blood pressure of 132 over 70, does that need to be reported? Yes. Good? Good. You okay? You sure? Do you need to go?
Oh, no, I'm good.
Okay. All right. Okay, so to get these numbers, we're going to use a gauge. This gauge is called a sphygmomanometer. It's easier to call it a blood pressure gauge. But that's its technical name. What we're going to do here to take a blood pressure, it's not a hard scale, guys. It's technical. We got a lot going on while we're doing it, but it's not a hard, in theory, it's not a hard scale. We're going to inflate the cuff. So we put air in, pump, 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 and the needle goes up. As a CNA, we stop somewhere between 160 and 180. That's our stopping point. We don't go beyond 180. 180 hurts, pain makes blood pressure go up. We'll get a high blood pressure because we instilled pain, not because I have a high blood pressure. So we go up to 180, and then we slowly let the air out, and that needle starts to come down. Now, as that needle is coming down, it's going to be quiet. There's no sounds at all. Silent, 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 quiet, 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 thump. Now, where we hear that first thump, where that needle is pointing when we hear that first thump, that is our top number. So we look, what is that? You know, what number does that little line correspond to? And that's our top number. Now, if we heard the first thump, we're going to hear more. So now we're hearing thump, 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 thump. And then we stop hearing thump. So where did we hear that last clear thump? Wherever the needle is, that line where we heard the last clear thump is our bottom number. And then we hear nothing else. It's quiet again, all the way back to 0. So we inflate, we deflate, we listen for the first thump and the last clear thump. The place where we heard the first thump is our top number. The place where we heard the last thump is our bottom number. That's the blood pressure. Now, the problem is that your brain will try to talk you out of this. You inflate and you deflate, and it's quiet, and it's quiet, and it's quiet, nothing's happening, and it's quiet. I don't think I'm doing this right. I don't know what I'm doing. Thump. I don't think thump. I thump. Am listening thump to what I'm thump. Oh, there's thumps. Oh, right. Your brain will talk you right out of it because this is quiet. It's supposed to be quiet. What was our normal range for our top number? 100 to 119. So this little section right here is where we should, if they're normal, hear our first thump. We inflated way up here. Do you see how much quiet there is? Don't let your brain talk you out of it. Okay? Now, there's 2 types of people in this world. 2 types of people when it comes to blood pressure. There's my dreamers and there's my dancers. And then some people like me, you're both, okay? My dreamers, in that quiet time, you'll have a hard time because when it's quiet, your brain wanders. You inflate, you deflate, it's quiet, quiet, I'm hungry, quiet, quiet, I wonder, quiet, quiet, thump, what I'm going to thump, have for thump, lunch today, thump, thump. Oh man, where did it start? I lost it because your brain was out picking daisies. Okay. So if you know this and you have a hard time with this, start working on strategies to capture your attention to what you're, following that needle and zoning in on what you're supposed to be listening for. Don't let your brain go wandering. Now, on the other end, I've got my dancers. Those people have no problem here, right? They inflate, they deflate, it's quiet. The first one comes up. That's great. No problem there, right? I got it. My dancers are my rhythm people, and heartbeats have a rhythm, right? Very rhythm. Now, the problem is with my dancers is that you really start paying attention to that rhythm. How many of you guys filled in that next beat? If you filled in that next beat, you're going to have a problem on the bottom because you're not going to be sure. Was it? Was there one there? I'm not sure. Maybe my brain filled it in. I don't know, right? You're going to have trouble on the bottom. So if you're my dancer, you have trouble with the top number because your brain went off and picked daisies. If you're a rhythm person, you're going to have a problem with the bottom number because it's a nice rhythm. And then it's not. Where was that last thump? Good? Makes sense? So if you understand this, you can work on strategies to be able to improve your performance going into it. Good? Good? Yeah. Learning blood pressure for me was super hard because I'm both. I am both. My brain just like went off on its own and then I was filling it. I'm like, I can't get this. It took me forever to figure it out. But once I did, I figured out a really easy way to teach it. So it's not quite so hard for you guys. All right, we have two pieces of equipment to help us with this measurement. So go ahead and open up your kits. Pull out your blood pressure cuffs and your stethoscopes. If you have an extra pieces, parts, little container thing like this, just put it right back in the bag. Hold that for me. All right, we're going to talk about the stethoscope first. Now, these are classroom stethoscope kits. You're going to leave them here at the end of today. If you want to practice this at home, you'll need to purchase your own stethoscope, a blood pressure kit. You can get them on Amazon pretty cheaply. Don't get the ones from like Walgreens or Walmart because the stethoscope is attached to the cuff and it doesn't always get placed right. Okay, so we'll learn about that today. So our stethoscope is our first thing that we have to talk about. This, the diaphragm, this thing, the head of the stethoscope, this is a microphone, but it only amplifies one side. So I actually have to tell this which side I want to listen to. Otherwise, it would amplify what I'm hearing, but also the AC, ceiling fans, people jiggling, it would amplify all this out here, and that would keep it from being effective. So some of you have double-sided, okay? You could have two diaphragms. The flat is a diaphragm, two diaphragms, or you could have a diaphragm and a bell. That's the kind of the cup-looking thing. Doesn't matter. We don't use the small side. We use the big side. We are listening for a wave of blood hitting the top of an artery, buried under muscle, fat, and tissue. It's not a big sound. We need a big microphone. We're going to use the big microphone. Good? Good? All right. So how do we tell this thing which side we want to listen to? Well, on your stethoscope, there's a little dot. There's a little dot. You want your big diaphragm to be on the same side as that little dot. You see, this one is not. The big diaphragm is on the other side of the dot. So this whole thing, if you hold it, this whole thing turns. The whole thing turns. Now that's important because if you order a kit from online, chances are when it's delivered, it'll be like this. It'll be backwards. You'll have to turn it. So the dot is facing the same direction as your large diaphragm. Good? Good? Okay. So just make sure that that dot and the big diaphragm are facing the same direction. All right. Now let's talk about these ear tips. This is the most missed step when people are taking blood pressures. This is the thing that most people get wrong because we put them in our ears the wrong way. And yes, there is a right way. So these ear tips, they're not completely straight. They're angled a little bit. Do you guys see that? How it's angled a little bit? these ear tips face away from you, not towards you, away from you. So put these ear tips, let's go. Yours are already, oops, where is it? Okay. Do you see how her ear tips face forward? This one they don't. This is what we want. So turn your ear tips so they face away from you and put them in your ears. And then very gently tap your large diaphragm. You should hear it pretty clear. Now take your ear tips out. Just flip the whole thing around. Put them in so they're backwards and do the same thing. You probably don't hear it as well, and it's probably a little more uncomfortable, isn't it? So take this out, flip it around, and do it again the right way so you can feel how they seat. Good? Make sense? In a few minutes, when we start taking each other's blood pressures, if you cannot hear the thumps, it's probably because you have your ear tips in backwards. Good? Good. All right. So let's move on to the blood pressure cuff. These are not one size fits all. They're one size fits most. But if we don't use the right size cuff, we'll get the wrong reading. So this white stripe on one edge, narrow edge of your cuff, there's a white stripe. This is your measuring guide. If I am concerned that this cuff is not going to fit my patient's arm, I place this white stripe underneath an inch above their elbow, so about an inch above their elbow, okay? I put this underneath, and if I can't see either corner, it's too small for my patient. I got to go up a size. If it wraps over halfway around the patient's arms, it's too big. So over half, too big. Can't see the corners, too small. If you use the wrong size cuff, it will give you a reading that is artificially either too high or too low. Good? Okay. While I'm showing you this, please do not inflate your cuffs at this point. Very important, because you will knock the gauge out of calibration. The gauge or the cuff has to be wrapped around something as you're inflating it. All right, so let's learn how to read this dial. You can see this dial on the front of your cuffs. Let's learn how to read the dial. You can see the 20s are marked, 20, 40, 60, 80, 100. Those are all marked with numbers. The big lines in between are your 10s. So this is the line for 20. This is 30. There's 40, 50, 60, 70, 80, 90, 100, 110. Big lines are your 10s. Good? Now the little lines, little itty bitty guys, those are worth 2. So right here, this is my 20. This is 22, 24, 26, 28, 30. Point to the line on your gauge for 47. Yes, it's a trick question. Point to the line on your gauge for 47. Does somebody want to correct me? There is no line. There is no 47. So if you give me an odd number for a blood pressure, I know you're guessing. Because you can't show me 135 over 79. Where is 135 on here? There is no line. Good? So if you give an odd number, the nurse knows you're guessing. And she's got to go back and recheck. So what we want to do is inflate this cuff, deflate it, and where we hear that first thump, where that needle is when we hear that first thump, whatever line that's on is your top number. Good. Now, automated cuffs can get odd numbers. That's fine because they're way more scientific than we are. Because we have to think about all the things we're doing while this is happening. Our hand is inflating and opening the dial to let that needle come down. So your hand is busy. Your brain's got to control that. Hand is busy. Your eyes are watching that dial come down. Your ears are listening for the sound. And your brain has to figure out what number that line corresponds to. That's a whole lot to happen in this little tiny space. Does that make sense? This is going to take a little practice for you. Today we're working on broad strokes. It takes a little time to really dial this in. About 45 blood pressures actually is what it takes to really start to dial this in, because you're going to realize in just a minute you don't have enough hands. You need one more hand. One more hand will make this way better. You're not going to get one. You got to learn to do it with two. But it gets easier as you try. Now, how this whole process works is through the bulb and valve assembly. The thing that looks like a hand grenade. We hold that in our dominant hand. Dominant hand. And when we hold it, you want to hold it so that the tube faces up like this. Not like this. This is not how we hold it. We hold it like this. And you want to hold it so that silver dial is facing you. And you can hold it with your thumb and index finger. So we're going to hold the bulb in the palm of our hand. We're going to close that valve off. Righty, tighty, lefty, loosey. So we turn it to the right just until it stops. Don't tighten it because we're going to loosen it in just a second. And if it's too tight, you're going to have to really, and then that needle is going to go, woo, and we're not going to get the numbers. So just until it closes. And then don't do this yet, but then we would inflate. When we inflate, that needle goes up. Everybody good with that? Good with that? This is the dial that controls everything. If your needle isn't going up, that dial is not closed. The air is not staying in the cuff. So if you're pushing, inflating, and that needle just does this, it doesn't go up, that means this isn't closed. Good? If that needle goes down way too fast, woo, that's you. You open this way too fast. If the needle stops, that's you. You got to open this more. So this whole thing is controlled by this valve, you. Good? Good? Okay. So when we close it, we're going to squeeze that bulb, get that needle up to somewhere between 160 and 180. That's as far as we go. We don't go over 180. Over 180 is not normal. Do CNAs do not normal? No. Remember on day one, we learned CNAs do normal. Nurses do not normal. Okay. So we inflate to somewhere between 160 and 180 and we stop. Now let me show you inside the body what's happening inside when this is happening. So we have a cuff wrapped around an arm. In that arm is an artery. And what we're going to do when we inflate that cuff is we're going to close off that artery. Air goes into the cuff, it pushes against the muscles, and the muscles just close off that artery. Good? Okay. Doesn't close it completely, but for our purposes, I'm oversimplifying this. Okay, this is 5th grade blood pressure. Okay, but we're closing it off. What we want to know is how much pressure does it take for that wave to push through this restriction? What is that pressure? So in order to find out, we're going to inflate to between 160 and 180. We're going to start to come down. Now, this artery closed off. But as we start to come down, we're releasing that pressure. So the artery's opening a little more, 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 a little more. Now, when that is happening, You've got all these waves that are being made by the heart. Heart squeezes, pushes out a wave. Remember? They're all lined up like cars at a toll booth. They're just lined up waiting. But right now, the artery is too small. They can't get through. So they're just hanging out waiting. As the needle comes down and the pressure decreases with our valve, that needle comes down, then that artery starts to open up a little bit more. So this artery is still too small. Still too small. Our waves can't quite get through yet. But at some point, as this needle comes down, that artery is going to be big enough that that wave can push through. And we hear that wave hitting the top of an artery down here, which means it came through. Got it? Got it? So we're going to use our microphone, our stethoscope, below the level of the cuff. And we're listening for that first wave that can make it through. And it's going to sound like a thump. So quiet, 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 thump. Where the needle is, when we hear that thump, is our top number. Good? Okay. So that thump actually has a name. It's called a Korotkov sound. And it could be really loud. It could be thunk, 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 thunk. Or it could be really soft, like tick, 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 tick. Everybody's a little different. Everybody's different. Okay? This is why I want you to kind of try out on several people, because everybody's a little different. So these thunk sounds are called Korotkov sounds. So we inflated our cuff. We started to deflate our cuff. We listened over the artery. And this is where we heard our first thunk. So this is our gauge. This is the line for 110. Remember, the bigger lines are 10s. This is our line for 110. So what would be 2 points below 110? 108. Remember, this is going backwards, down, not up. So it wouldn't be 112. Right? 112 is up here. This would be 108. Good. So our top number for this patient, for their blood pressure, is, whoops, what did I do here? Hold on. 108. Good. Questions? All right. Now we're not done. We got one of the numbers, but we need the other one. So if the first wave was able to make its way through, well, the others can too. So we'll hear more thunks. Thunk, 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 thunk. They're going to make their way through. What we're trying to find, okay, remember that, I think I missed some, hold on. I think I'm in the wrong. Yeah, I guess I was right. Okay, sorry. Okay, so in the artery, we have a wave of blood, a valley, a wave, a valley, a wave, a valley. We're measuring how much pressure is inside when a wave goes through, how much pressure in between waves. When a wave goes through, that's our top number. In between waves, that's our bottom number. So we heard that first thunk at 108. Then we heard more thunks. Thunk, 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 thunk. But they're going to get softer as they go. So thunk, 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 thunk. Where was that last one? Because what is happening inside the body when we're hearing this is we're still decreasing that pressure, that we're letting the needle go down. So that artery is getting bigger and bigger and bigger and bigger and bigger. And these last waves, they're having to really kind of reach and touch the top of that artery. So the sound is faint. Okay, so it starts out really strong because the artery is right up around that wave. Then as the artery gets bigger, the wave gets smaller inside of it. And it goes down in sound. Thunk, thunk, thunk. What we want is the last clear thunk. Where is the needle when we hear the last clear thunk? And then at some point after that, there's not going to be any more thunks. It's quiet because our artery is wide open and the waves can't touch the top anymore. So where the last thunk, the last clear thunk that we heard was where the needle is on the dial when we heard the last clear thunk is our bottom number. So in this case, it was 1 tick above 60, which would make it 62. Is this a normal blood pressure? 108 over 62. Yep. This is our normal values. 108 falls between 100 and 119. 62 falls between 60 and 79. This is a normal blood pressure. We just document it and move on. Questions? Good. We want to make sure that needle gets all the way to 0, though, because you'll get excited. Oh my gosh, I heard it. I got it. It's 108 over 62, and your needle is still kind of hanging out there, putting pressure on that artery. Get that needle all the way to 0 before you celebrate. Okay, good. Good. All right, when you're practicing, you're going to want to do this over and over and over and over and over again because you're I think I heard it. Let me try again. I think I got it. Let me try again, right? Remember that is an arm and we are closing the artery. That arm is going to get really unhappy with us really quick. So you take a blood pressure twice on one side. Then you move to the other arm. Then you move to another patient if you can't get it. Okay? Don't take the same blood pressure over and over and over and over on the same arm because you'll hurt the person that you're working on. Good. Now, you should consult the care plan for which arm we're taking a blood pressure on. If the care plan doesn't tell us, then you should ask the patient, which arm can I use? If the patient says, I don't care, we go with the left. Left is best. If there's a reason we can't use the left, it's got an IV, the patient has dialysis and they have a shunt in that arm. If the patient has a cast on that arm, if the patient's had a mastectomy and we remove the breast and the lymph nodes, we can't use that arm. There's a lot of reasons why we wouldn't be able to use a certain arm. So we're going to go by our care plan and our patient. If there's no contraindications, left is best. There is a slight blood pressure difference between left and right. And that's just because of vessel size. Our heart's on the left. The blood vessels on the left are a little bit bigger. So that affects the blood pressure a little bit. Not a lot, but a little bit. Good? Questions? Okay, so let's give this a mechanical try. Okay, let's see if we can figure out how to use this whole bulb and valve assembly. So we are going to wrap our cuff around our can with the cords hanging down. Like this. Let me see yours real quick. We got a problem here. Hold on. I'm going to borrow this real quick. Okay, there we go. You're welcome. You're good. You're good. You want some help? You're good? Good? Okay. All right. So you have your cuff wrapped around your can like this. This flap that's in your way, tuck it behind. And you should have this facing you, held in your non-dominant hand. So if you're right-handed, it should be in your left hand. So I'm going to turn around so you can see what it should look like for you. Everybody with me? Okay. All right, Jake, you're going to zoom for me. Okay, this is what I'm going to show you on this gauge. You should be able to see it up here.
There we go.
Nothing wants to work today. It's Monday. Tilt it up. Trying to get that. There we go.
All right, I'm going to manually adjust focus here. Does not want to focus very well.
Let me move it. Maybe
There
it'll.
we go. It's just having issues. It wants to focus on the TV.
Yeah.
Let me bring it down just a little bit so it's not framed.
There we go. Okay. So this is what your gauge should look like as you're in. I'm trying to get that glare off of there. Sorry, guys. There we go. Okay, we're going to go up to somewhere between 160 and 180. I'm going to hold, where is it? Hold this silver dial in my fingers, and I'm going to turn it ever so slightly to the left. Do you see how little I'm turning it? I mean, it's tiny, 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 tiny motions, and my needle starts to come down. As it slows down, I have to open a little more. As it slows down, I have to open a little more. As it slows down, I'm opening a little more, and I'm opening a little more, and I'm opening a little more, and a little more, all the way to 0. Good. So let me do that one more time.
My apologies.
No, that's my fault. I'm sorry. Let's do that one more time. And I want you to pay attention to the speed of the needle. Oops, that's way too fast. Hold on. Okay, do you see the speed of that needle? It should never go any faster than that. Bless you.
Thank you.
You guys see the speed? Kind of like a second hand in reverse. That's how fast it should be going. If it goes like this, you're going to miss the number. Because by the time your ear hears the thump, the needle has gone way past where your eyes can notice where it was. Okay, so go ahead and give that a couple tries. Just inflate and deflate a couple times. Okay, if it's not inflating, it means that we aren't closed.
Oh, okay.
So we're gonna, are you right-handed or left-handed?
Left.
Okay, you're good. So righty-tighty.
Mhm.
So we're gonna turn it to the
Okay,
right until until it stops. Don't over tighten it.
Right.
Okay, now inflate.
Okay.
There you go. Okay, once you have the mechanics of it down, once you've inflated and deflated a couple of times, you can take your cuffs off of your can. Notice how little you move that silver dial. I mean, it's so small. Your motions are so small. If you turn it a lot, that needle goes, woo! Okay, so let's talk about where to put the stethoscope. We need the brachial artery, which is different than the radial artery. Remember, the radial artery was at the wrist on the thumb side. You guys remember that with pulse? Radial was here on the thumb side. The brachial Okay, if you put your arm out straight, get that elbow popped up. You want this as straight as possible. So if you get your arm straight, the brachial is on the pinky side, not the thumb side, the pinky side. So at the fold of your elbow where the lines are, 2 fingers, not your thumb, on the inside, so like the pinky side, put 2 fingers there, put your thumb on the back, and see if you can feel your thumps. See if you can feel your thumps. If you can't feel your thumps, make sure that arm is straight. If it's bent at all, you won't be able to feel it. It is not in the middle. It is on the pinky side. Did you find it?
Not sure if it does or not.
I want to be a little bit more. Press harder.
Now I do.
Okay, got it? Okay, we want to be at the lines, not above the lines. There you go. So thumb on the back. Put your thumb back here. Push. Okay, let me feel. Yeah, you got a lot of muscle there. Yours is actually right here. Yeah, it's-
Normally, I always check my carotid on my radio.
Yep, it's right here, but it's pretty deep. You've got a lot of muscle there. Did you find yours? Find it? No? Okay. Did you find yours? Okay. So straight arm, you want it as up as you can. And yours, let me see here. Yeah, yours is hard to find.
Yeah, they, I'm really hard to get.
Right here under this finger.
Okay. Yeah, I can feel it.
So get that arm run nice and straight. Boy, you guys are all hard. Wow.
I think mine starts in the middle.
Ah, here it is.
Yeah.
All right. Do you feel what I just did? Do you feel how I kind of wiggled back and forth? What I'm doing, you've got a tendon that lays right over yours. So yours is right here. So if you have trouble finding, set your fingers down, wiggle back, forth, and in. And it usually pushes that tendon out of the way. Did you find it? Did you find it? Got it? Okay. So if we're listening for a wave of blood hitting the top of the artery, we have to make sure we're over the artery. Because if not, it's like a microphone. If I have a microphone here, you're going to hear me. But if I put the microphone over here, it doesn't do as much good. So we have to make sure we're over the artery. So find your artery, put your cuff in place and secure it, and make sure you put the stethoscope where you found the artery. Well, the good thing is that your blood pressure cuffs actually have artery markings. So you lay this on the arm, you find the artery, you line up the arrow. And now you know exactly where to put your stethoscope. Okay, good, good. All right, let's go to page 57 real quick, and I just want to show you this, and then we're going to have some practice time. So on page 57, we have our questions here. Let's go to number 8 real quick. It's this is our graphic for questions 8 and 9. And I know it's small, but can you tell me about what this blood pressure might be? Where did we hear the first thump? What line? The first, not this one. Okay, 130. Where's the last thump? 90. So what is this patient's blood pressure? 130 over 90. Is that normal? What do we have to do with that? Yeah, report it to the nurse. Let's go down to this one. Where is that first thump? 108? Everybody in agreement? Where's the last thump? Yeah, it happens to be the one we used for our instruction earlier. So yes, 108 over 62, and we already determined that was normal. Good? You guys piecing it together a little bit? It's not nearly as hard as it seems. What's hard is there's a lot going on at the same time. Our hands have to control that bulb and valve assembly. Our eyes have to keep track of that needle and pay attention to what number. Our ears have to listen for the thumps, and our brain has to figure out what number that line is associated with. So there's a lot going on at the same time with this, and it takes a little bit of practice to get down. Good. All right, so we are going to break up into groups. So you three are going to work together. You two are going to work together. You three are going to work together. You'll take each other's blood pressure. Okay. See, two. Actually, I can do two groups of two. We have an even number. Yay. So I'm going to ask you to come here and sit in this chair with your blood pressure kit. And I'm going to ask you to come sit in this chair with your pink shirt. What's your name? Jenny. Come sit in this chair. So now we have groups of two. Take each other's blood pressure and then change groups. I want you to take blood pressures on at least 3 people today. In 15 minutes. No pressure, right?
I know this is probably going to be completely accurate because we're all like learning this. So.
You're not going to be accurate. It takes 45 blood pressures, so you're not even in the ballpark today. What I want you to get used to is, well, and I'm going to talk about the sounds, is the mechanics of it. Putting the cuff on, inflating, deflating, kind of putting the pieces together. At the end, I'm going to ask you, did everybody hear a set of thumps? As long as you heard thumps, we are successful today.
Want to go first? Want to go first? What do you want to do?
Try to have the arms supported on a surface, not hanging out in midair. And everybody's blood pressure is likely to be a little high today because you're learning a new skill. No. Okay, while my students are practicing, I'm going to go ahead and sign off of our virtual. Thank you so much for joining us today. We truly appreciate it. And we will be, game show is tomorrow on our YouTube channel at 11 a.m. Hope to see you there. We're going to be talking about the facts framework, how to demystify the written questions. So catch us on our YouTube channel for your CNA at 11 a.m. tomorrow. And then Wednesday, we will be back in class at 9 a.m. And the last hour of Wednesday's classroom live stream is going to be on test registration. So tune in for that as well. Until next time, happy caregiving. Bye.